And Representative Arford.
Good morning, Madam Chair. My name is Representative Poppy Arford, and I represent District 49, the western part of Brunswick.
Representative Quint.
My name is Tracy Quint. I represent House District 144, which is 17 towns in Aroostook and Penobscot counties.
Great. Representative Connor.
Good morning. Thank you, Madam Chair. My name is John Connor, and I represent part of Lewiston.
Representative Evans.
Thank you, Madam Chair. I am Representative Richard Evans. I represent House District 120, including the towns of Atkinson, Brownville, Dover, Foxcroft, Medford, Milo, Honorville Township, and Lakeview.
Representative Blyer.
Thank you, Madam Chair. Good morning, everyone. My name is Mark Blyer. I represent District 22, which is Leamington and part of Buxton, Standish, and
Representative Brooks.
Good morning. My name is Heidi Brooks. I represent House District 61, which is part of Lewiston.
Representative Melrano.
Good morning. I'm Gina Melorano. I represent House District 62, which is part of Auburn.
Representative Morris.
Good morning. I'm Representative Joshua Morris. I represent House District 75, which includes the communities of Turner, Leeds, and Livermore.
Senator Stewart.
Good morning, folks. I'm Trey Stewart, State Senator in District 2, which includes 51 communities in Aroostook and Penobscot counties. I reside in Presque Isle, and I'm happy to report that over the weekend, the Presque Isle Wildcats were successful in both of their endeavors over the Ponies, who are from Foxcroft Academy. And so I have to just make sure that folks are aware of that our team was successful over the weekend over my good colleague, Representative Evans' team down in Foxcroft. As we head into tournament season, I'm sure there'll be more activities to report on.
Good to know. I assume they were playing basketball. Is that right, Senator?
That is correct, Madam Chair.
Okay.
Yeah.
Senator Brenner, go ahead.
Thank you, Madam Chair. My name is Stacy Brenner. I represent Senate District 30, which is all of Gorham, most of Scarborough, and part of Buxton.
Representative Tepler.
Good morning. My name is Denise Tepler, and I serve as that House co-chair of the committee. I represent the town of Topsham, which is House District number 54.
And good morning, everyone. I'm Senator Heather Sanborn. I represent Senate District 28, which is half of Portland and half of Westbrook. And we're helped out today by our clerk, Edna Cayford, although I don't see her square on my screen at the moment, but she must be here somewhere. And also by Colleen McCarthy-Reed from the Office of Policy and Legal Analysis, which is going to be extremely important today as what we have on our plates today, first of all, is that we are going to take up a bill 1776, which we had previously voted on, but which we ran into some snags on language review. And so we're going to reconsider our action on that bill and have some additional committee action on the language there. Hang on just a second, Representative Tepler. I'm just going to lay out the full agenda for the day so people know how we're going to proceed. And then my plan is to take up the 5 mandate reviews, and it might be a little more than 5 because we've got a couple of studies that actually encompass a couple of different LD numbers, and to take them up in the following order. This is helpful, I think, for folks who might be tuning in. So the approach today, I think, would be actually to take them up in the order that they come by LD number, except for that our discussion about LD 922 and 1539 would both be at the end. So it would be LD 441, LD 665, LD 1003, LD 1357, LD 922, and LD 1539 would be our plan. We are going to break for lunch at some point in there as well. depending on how long our discussions go, we'll find a good spot for lunch. So that is the plan. I know we've got a number of folks in our attendee space who are here for different bills. So if you were here, for example, for the fertility discussions, those are likely to be some hours from now. So just to let you know where we are. Okay, so with that, I would like to open a work session on LD 1776 first. And Representative Tepler, I think you have the motion to reconsider. Go ahead.
Thank you, Madam Chair. Having voted on the prevailing side, I move that we reconsider LD 1776.
Is there a second? Seconded by Senator Stewart. I anticipate this will be unanimous, so we'll use our technique where we put our hands in our physical window to indicate our assent to the motion. Motion to reconsider, Representative Arford, Representative Quint. Okay, that's unanimous of those present. And so now LD 1776 is reopened for our consideration. And Representative Tepler, do you want to make another motion just in the interest of expediency here?
Sure. I move that we vote ought to pass this amended on LD 1776 with amendments that have been suggested by, I'm sorry. Should I stop there? And
no,
allow
go ahead. I just wanted to make sure we were being very specific about which amendments, because Mr. Moran has suggested a number of amendments. So I just wanted to make sure we were laid about very specifically. Go ahead.
Okay, so specifically, the amendments are first, that any prescriber may notate on their prescription that no emergency refills of the prescription are permitted. They may is the important word there. And secondly, that the drugs in the categories of scheduled drugs in the categories of 1 and 2 are not permitted to have emergency refills, and schedules 3 and 4 will be allowed to have 7-day emergency refills, and all other medications that will be used for chronic treatment of certain conditions may be refilled for 30-day emergency refills at the discretion of the pharmacist.
So, Colleen, I think we would want to keep that same language where we talk about the 30 days and the up to 30 days, but include the schedules in that same section. And use the up to 7 days language and up to 30 days language there in that section. Does that make sense?
Okay. I had drafted it in separate paragraphs, but that's okay.
Oh, okay.
So
it could be separate paragraphs. That's fine.
Okay.
Do you want to share your screen with us so that we can see what you did?
I think, yeah. Would you like to see what I think Representative Tepler just said?
Yes, I would.
Thank you.
The only thing that is not in this draft is the additional recommendation that Mr. Moran made about allowing a prescriber to note on the prescription that an emergency supply is not permitted. I haven't added that yet, but the other provisions I can go through. And so I'm assuming this will also carry forward some of your other changes that were in your previous
all of them
amendment. Yeah. Okay.
Yes. The only
Colleen, I forgot I asked you to draft this, so my apologies.
Okay. That's okay. It's good that you can kind of see it. It's probably a good idea, right?
And we do want to add that provision regarding the prescriber.
Mm-hmm.
Right.
It's in the motion. Yeah. But let's have Colleen share the screen so everybody can see what we're talking about.
Okay. So let me. So I think everybody can see this. So let me see if I can get it up here. So I think this is shows the changes from the original bill to LD 1776. And as I mentioned, This would, I think, carry forward all of the changes that Representative Tepler articulated, except the addition of language allowing the prescriber to prohibit an emergency supply on the prescription, give them that authority, but it would take off the emergency. The language related to insurance coverage would be replaced, and that's here in this section 1, and it would say that carriers must make available coverage for emergency supply of a chronic maintenance drug in the same manner as coverage for other drugs under the health plan. And it does add a sentence that allows carriers to impose a deductible or other cost sharing for the chronic maintenance drug, as long as the amount of that cost sharing is applied in the same manner as if the maintenance drug was dispensed as prescribed by a provider. And then it also does add a provision related to health plans offered for use with a health savings account, that the section does not apply to those plans unless the IRS determines that the benefits are permissible benefits. So that's the provision related to insurance coverage. And then in section 2, which addresses the authority of a pharmacist to dispense emergency supplies, you'll see the conditions under which a pharmacist may sell and dispense are laid out in subsection 2. Paragraphs A and B were from the original bill, that the pharmacy must have a record of the prescription in the name of the patient requesting the supply. The pharmacist has attempted but is unable to obtain authorization to refill the prescription. In the pharmacist's professional judgment, the drug is essential to sustain the life of the patient or to continue therapy for that chronic condition. And failure to dispense and sell may reasonably produce undesirable health consequences or cause physical or mental discomfort. Paragraph D is the provision that provides that the amount of the drug dispensed and sold does not exceed a 30-day supply as provided in the prescription, or if the standard unit is more than a 30-day supply, the amount of the drug dispensed does not exceed the smallest standard unit of dispensing. It does provide that the pharmacist shall exercise their professional judgment to determine the amount of the drug to be dispensed or sold up to the maximum amount. So a pharmacist could determine under this language that to provide less than a 30-day supply. With these exceptions, with respect to a drug that's schedules 3 or 4, as Representative Tepler articulated, the amount of the drug dispensed does not exceed a 7-day supply. You had previously discussed adding a provision that pharmacists may not dispense or sell a particular drug in an emergency supply to the same patient more than twice in any 12-month period. And then here's the provision related to Schedule 1 or 2 drugs. The chronic maintenance drug is not a controlled substance, including an opioid medication included in Schedules 1 or 2. And then paragraph H is the notification that the pharmacist is required to notify the practitioner who issued the prescription no later than 72 hours after the drug is sold or dispensed. And then I would also add a paragraph I, which is the language that Representative Tepler mentioned about giving authority to the prescriber to note on the prescription that an emergency supply may not be issued pursuant to that prescription. And then the last change that you discussed earlier was making the rulemaking provision for the Board of Pharmacy discretionary, so changing that shall to may.
Colleen, can you go back up to section 1?
Yes, I can. This one related to insurance coverage?
Yeah. Oh, and item 3. I think that there's a word missing.
There's a typo there. Yeah, it
Okay.
should say does not apply. Yep, thank you. I noticed that too as I was going through it. Do you want me to stop sharing or pull up anything else for anyone?
Does anyone else need any clarification on any of the language? Okay, I'm not seeing any additional hands, so I think you can stop sharing. Is there further committee discussion with regard to the bill? Representative Melrano.
Thank you, Madam Chair. I'm not sure if Representative Tepler's motion has been seconded. If
I
not,
think it hasn't been.
Oh, okay, I'll second it.
Great, thank you. And Colleen, I think you're aware that Edna got kicked off of the meeting somehow and is still not back. So I think you are our clerk for the moment, if that's. Oh, she just got back.
Oh, okay, good.
Oh, good. Okay. All right, good. All right.
I'm ready, though. I had.
You're ready.
Voting.
Okay. Is there any further discussion with regard to the bill?
I'm still not showing on there.
So I just wanted to say and wanted to thank the sponsor of the bill, who I know is listening and is in our attendee space. But I think this is a bill that really walks a delicate balance between different professionals that are involved in our healthcare system. And I appreciate the constructive suggestions that we have received from the medical provider community on the physician and the PA side over the last couple of weeks. I think this accomplishes largely the goals that we had in place, which were to observe or to honor the professionalism of the pharmacists in being able to fill gaps and keep people safe when all else fails. So I'm pretty confident that these changes still allow for that professionalism to shine through, and proud of the work that we did to get here, because I think this bill is going to be able to become a law. So I guess I would just say that it is certainly a product of compromise, but it's something that I think reflects the professionalism of the pharmacist profession in a good way. Are there any other comments before we vote? Representative Brooks.
I also want to echo that and thank the sponsor. It definitely, to me, it indicates something that's been a problem, especially during the pandemic, especially with the medical system stretched. And also, so I'm really happy with the bill language. It also strikes that balance of how do we work with the medical team and the patient, putting the patient at first, and trying to account for situations beyond anyone's immediate control.
Thanks, Representative Brooks. Okay. Seeing no further hands, I think we're ready for the vote. Edna, we had a motion by Representative Tepler and a second by Representative Matheson.
Melrano.
Melrano, I apologize. They were right next to each other in my screen. And second by Representative Melrano, and it's ought to pass as amended on LD 1776. And you can go ahead and call the roll.
Thank you. Senator Sanborn.
Yes.
Senator Sanborn, yes. Senator Brenner.
Yes.
Senator Brenner, yes. Senator Stewart.
Yes.
Senator Stewart, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Representative Arford. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Melrano.
Yes.
Representative Melrano, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Quinn.
Yes.
Representative Quinn, yes. 12 members of the committee voted in the affirmative and 0 in the negative.
Great, thank you. Okay. So next we are going to turn our attention to the mandate reviews. And Colleen has outlined them for us on a single chart, I think. So, but we're going to take them in order. So we will open a work session on LD 441, and I'll ask Colleen to present that portion of the chart for us.
So as Senator Sanborn said, the first one that the committee is going to take up is LD 441. This was a carryover bill from the first regular session, an act to expand adult dental health insurance coverage. There are two parts to the bill. Part A of the bill relates to insurance coverage, and Part B relates to some requirements for the Maine Health Data Organization. But under Part A of the bill, it would require health insurance carriers, both individual and group, to provide coverage for comprehensive dental services. As it was drafted, the bill would apply to policies and contracts issued or renewed on or after January 1 of 2022. Part B of the bill would require the MHDO to develop and maintain a database of dentists providing dental care to Maine Care members, including children, and to post that information on a publicly accessible website. A couple of things to keep in mind related to this bill. One is that I think committee members are aware that pediatric dental benefits are required to be included in essential health benefits package under the federal ACA, but it does not extend to adult dental benefits. You are also, I think, aware that dental coverage is already available as a standalone product in the insurance market that provides coverage for adults both under individual policies and under group policies. One of the things that was noted in the report from the Bureau of Insurance and in the previous discussions that the committee had is the bill does define comprehensive dental services, but it was suggested that the committee, if you move forward, might consider further clarifying the scope of what that means. It is a broad definition, so there are some questions about some of the specific dental services that would be required and whether or not there might be any cost sharing parameters that the committee is interested in. As the bill is drafted, it's sort of silent on cost sharing, so it would permit carriers to apply any cost sharing requirements to the benefit. So if the committee is interested in moving forward, that might be something you want to think about. And it will, if you do specify specific cost sharing, that will impact the overall costs, premium costs of the bill. I also mentioned that as the bill was drafted, it has an application date of January 1 of 2022. Given the bill was carried over and there's been the passage of time, if you do move forward, consider amending the application date to January 1 of 2023 or later. One of the things to keep in mind, I think, is that as you are all aware, when we've discussed this before, the timing and implementation for carriers that are required to file their rates, proposed premium rates for the 2023 plan year is coming up in early to late spring to allow for review of those rates by the Bureau of Insurance. So consider whether or not 1/1/23 as an application date is appropriate, or a date further in the future, as you and that applies not only to this bill but the other bills that you're going to discuss today. And then lastly, I just noted for you the potential financial impact of the legislation that was included in the Bureau of Insurance mandate review. In terms of a premium impact, the estimate ranged from $15 to $22 per member per month. They did also include the potential cost to the state for defraying costs of adding this as to the essential health benefits package. That was estimated to range between 11.7 million to 16.5 million. I would note that I'm not aware And the report notes of any state that has been required by the federal government to defray these costs, but it is something that is included in the federal Affordable Care Act. So it has been included in the mandate reports for your purposes of your discussion. And then the last potential impact to consider financially if the legislation moves forward is the costs of adding this as a required benefit under the state employee health plan. Anthem provided an estimate, as they are the third-party administrator for the state employee plan, of $12.20 per member per month. The state employee plan does have a standalone dental benefit currently as well. It's something to keep in mind. And while paragraph Part B of the bill, as I noted, would require MHDO to develop and maintain a database of dentists providing dental care to main care members, I would remind the committee that comprehensive dental benefits were added to the main care program as part of the biennial budget last session, and that is just being implemented now. So if you think about including some of the language in Part B, you might expand that language to include not only dentists who provide dental care to children, but also to adults under the main care program. I think I'll stop there, but I'm happy to answer any questions specific to the report. I know that folks from the Bureau of Insurance are here if you have any questions for them, as well as other interested parties in the attendee space. I guess I'll stop.
I put myself on mute. Okay, are there questions for Colleen? Let's start there. I don't see any. All right, so seeing no questions for Colleen, I will ask if there is committee discussion. Hot bench today. Representative Brooks, go ahead.
So I was the sponsor of this bill. The issue of dental care is near and dear to my heart. I mean, we all have teeth, and we recognize to a greater or lesser extent how dental, not preventing dental disease, having a toothache can impact the quality of our lives. There was a constituent of mine who had dental pain. She was a young woman. And it was difficult for her to find care financially and literally. So when she was able to find care, they recommended an extraction. This was a while ago. When the extraction was recommended, she was able to borrow money to get some care, and it turned out to be a cavity that was filled. And so this bill, we had a bill that was more expansive last session. Last year, the bill was brought up, and I think that it is important. I think with the report, there were a couple of key points as far as how the most common cause for ER visits was dental pain I think it was 14 to 44, something in that age range, and how there would be a big upfront cost, but that over time, that prevention and early intervention helps. So those are just some initial thoughts.
Okay, Representative Tepler.
Thank you, Madam Chair. I really appreciate the sponsor bringing this bill forward, because I believe she's fighting for something that is the way it should be. In an ideal world, we would connect dental health and other parts of our body's health together, and we would be able to provide dental care as part of overall health care. However, as far as health insurance goes, this is far from an ideal world. And with the costs that the Bureau of Insurance and Ms. McCarthy-Reed have outlined here, I can't support the bill at this time, although I recognize it to be the best way to take care of people. Thanks.
there further discussion from the committee? Is there a motion? Representative Morris, go ahead.
Thank you, Madam Chair. I will move ought not to pass.
Is there a second? Seconded by Representative Quint. Is there further discussion on the motion? I'm going to note that there is a Part B to this bill that would require an online database of providers. I am comfortable with an ought not to pass rather than voting on Part B, in part because I think that HHS is a much better committee to be mandating that Maine Care put together directories. And also because I noted when I looked to see if I were an adult eligible for dental care on Maine Care, how would I find a dentist, that there was a very clear 1-800 number that I should call, and that an actual human being would help me find a dentist. And that seems like a good solution for the moment. And HHS might want to consider whether they should also have an online option for finding a dentist, but I was satisfied that if someone needed to find a dentist and had coverage through Maine Care, they had a human being they could call on an 800 number to get that information. So I am comfortable with the ought not to pass on this bill as well. Are there any additional comments? Representative Arford.
First of all, I would like to commend Representative Brooks for bringing this bill to us. We are kindred souls in that we both support universal publicly funded healthcare, as I truly believe that's the only pathway forward for comprehensive, affordable healthcare, which includes dental services for all Maine residents. However, I will not be voting in favor of this bill, as the cost for subsidizing the people on our exchange, the individual people who will be securing insurance there, if we were to pass this bill, the cost to the taxpayers of the state of Maine would, in my mind, be excessive at this time. And where we really need to go to is a complete comprehensive package for all Maine people. And we will continue to work on that. But again, I do want to commend Representative Brooks for her courage and her hard work in supporting this policy.
Okay, seeing no further hands, I will ask the clerk to call the roll.
Thank you. Senator Sanborn,
Yes. Yeah, it's ought not to pass. Yes, sorry.
Senator Sanborn, yes. Senator Brenner,
Yes.
Senator Brenner, yes. Senator Stewart,
Yes.
Senator Stewart, yes. Representative Tepler,
Yes.
Representative Tepler, yes. Representative Alford,
Yes.
Representative Alford, yes. Representative Blyer,
Yes.
Representative Blyer, yes. Representative Brooks,
No.
Representative Brooks, no. Representative Connor,
Yes.
Representative Connor, yes. Representative Evans,
Yes.
Representative Evans, yes. Representative Matheson,
Yes.
Representative Matheson, yes. Representative Melorano,
Yes.
Representative Melorano, yes. Representative Morris,
Yes.
Representative Morris, yes. Representative Quinn,
Yes.
Representative Quinn, yes. 12 members of the committee having voted in the affirmative and 1 in the negative.
Okay, thank you. All right, the next
Oh,
bill.
excuse me.
Oh,
I just
go
need to
ahead.
know Representative Brooks' minority report. What would it
Okay,
be?
what I'd like to do is have it as if it was an ideal world, and have the definition of comprehensive care right now match what Maine Care has. So
Mhm.
preventative and pretty comprehensive, according to the Maine Care current definition. And then more first dollar coverage, so not subject to deductibles, or co-insurance, but counting towards Well, I'll just say that. I'll just say first dollar coverage. If you know what that means, yeah.
Do.
And then going down the line, I would include the state employees. And
Okay.
then the other question is, or the other part is part B. I think that's all part A, correct?
Yes, that's part A.
Yeah. Okay, and then part B, I would also have an online service and fund maybe additional navigators to help answer the phones. If it's necessary. But you can have it so that we fund at least one more position for a call person to talk to.
Okay. Okay, thank you. And starting in January of 2023?
Yeah, 2023, please.
Okay,
Yeah.
great. Nope, thank you. I have enough for the amendment. Thanks. Sorry to interrupt.
Sure.
Oh, thanks for the reminder. We've been doing so many unanimous votes out of this committee. I had forgotten what to do when it wasn't. Okay, LD 665 is the next bill that we will take up. So I'll open a work session on LD 665 and ask Colleen to present her bill analysis portion of the chart.
Sure. So LD 665, this was a bill related to dental care for cancer survivors. And for this, for the purposes of the mandate review that the Bureau of Insurance did, you asked them to look at two proposed amendments that were discussed by the committee last year. Option one was an option that was put forward by proponents of the bill, and option two was some language that was developed with input from carriers, and there wasn't really a they didn't come to consensus at that time, and the committee was making a recommendation to have the Bureau review the proposal pursuant to the statutory criteria. So you asked that the mandate report consider both options. So under option one, it would require coverage for medically necessary dental procedures for an enrollee who has been diagnosed with cancer prior to beginning cancer treatment, including chemotherapy, biotherapy, radiation therapy treatment, and fluoride treatment. The language would require coverage to be provided for those procedures that are medically necessary to reduce the risk of infection or to eliminate infection or to treat tooth loss or decay that are the direct or indirect result of cancer treatments. And then under option two, it's similar language, but it would require coverage for medically necessary dental procedures for someone diagnosed with cancer to begin cancer treatment, including those therapies, and that coverage must be provided for those procedures medically necessary to reduce the risk of infection or to eliminate infection or to treat tooth loss or decay. The mandate review that the Bureau of Insurance submitted noted that pursuant to their analysis, they believed that under option one, that would apply to someone who has any type of cancer diagnosis. And option two, by its language, would appear to be limited to those who have head or neck cancers, diagnosed with head and neck cancers only. So that's one of the differences. And then their report also noted the potential impact in terms of how many cancer diagnoses there are in Maine. Their report noted a little over 9,200 expected diagnoses in 2023. And if you focus just on head and neck cancers, 2,685 in terms of the potential impact of the legislation on an annual basis. The report also noted that there was under option two, sort of routine fluoride treatment would not be included, but there would be some recommended treatment potentially for fluoride treatment for those who have head and neck cancer. So that's something the committee may want to consider moving forward. The other part of the report that I just wanted to remind folks about is that for purposes of their analysis and financial estimates, they did not assume that coverage would be required for dental implants, but in their review, wanted to note that there may be some instances where a dental implant may be part of recommended treatment, particularly for someone who has head and neck cancer prior to beginning radiation therapy. The legislation, as with LD 441, does not have any specific cost sharing parameters. So any cost sharing would continue to apply pursuant to the enrollee's health plan unless you change the language. So you may want to consider thinking about specific cost sharing parameters. And as I mentioned previously about the application date, if you move forward with legislation on this issue, consider an application date of 1/1/23 or later, taking into account the timing and implementation needs of carriers required to file their rates for the 2023 plan year. And then just summarizing briefly the financial impact that was outlined in the report. Option 1 under the analysis is the range is, they're very close in terms of the per member per month impact on premium, but option 1 goes a little bit higher from 26 cents to 64 cents per member per month. Option 2, the range in the report that's noted is 23 cents to 59 cents per member per month. In terms of the potential cost to defray benefits, that would go beyond the essential health benefit plan for qualified health plans under the ACA. Those estimates range from 194,000 to 477,000 under option 1 and 172,000 to 440,000 for option 2. And the potential financial impact on the state employee health plan, the estimate was 23 cents per member per month. I'm happy to stop there. I also could, if the committee is interested, could pull up the proposed statutory language if you're interested in looking at either option 1 or option 2 further.
So, Colleen, as we discussed this in our caucus prior to today's meeting, we were well and truly baffled by option 1 and option 2. Yep. They both use to begin or prior to, but then there's a discussion in the actual text about 18 years of treatment and 24 teeth being extracted, which didn't seem like it was covered under either option 1 or option 2. But I just didn't understand what the difference between option 1 and option 2 even could potentially be, because option 1 sounds broader. It talks about the effects of cancer treatment on your teeth, but then it talks about beginning cancer treatment. And so we got ourselves pretty tied up in knots. I don't know if you can help us with that, or if there's somebody from the Bureau that we should bring in to try and unsnaggle that, but it seems like I couldn't even tell whether option 1 was broader than option 2 or vice versa.
Yeah, I mean, I think part of it is we were taking what language had been suggested to the committee during your discussions last time, that, as I mentioned, option 1 was something that was suggested by proponents of the bill. And then option 2 was language suggested by carrier representatives. So I think there was some interest. So I think option 1 is meant to be broader than option 2. And I think, you know, prior to and beginning cancer treatment, you know, maybe, you know, I think the committee would want to be clear about what they mean, but I think it seemed reasonable how the mandate review report interpreted that difference, you know, that prior to beginning treatment, which is the language in option 1, talks about, you know, really relates to any cancer treatment that would be needed. And to begin cancer treatment really seems more focused, so that, you know, you need to have this in order to be, you know, have the proper, you know, dental state to begin that treatment. And that's where I think they focused on that would mean only head and neck cancers under option 2. So those, I think, are going to be questions for the committee to think about. And option 1, I think it seems reasonable to think that option 1 would apply to any cancer diagnosis. And if there's going to be any dental care that might be necessary, as a, you know, that indirectly or directly relates to that cancer treatment, then if it's medically necessary, it would be covered under option 1. And under option 2, those medically necessary procedures that would be covered would be limited to sort of those specific types of cancer, if that helps.
Yeah, so I see now both options require coverage for tooth decay that's the direct or indirect result of cancer treatment. In option 2, would it be just head and neck cancer?
I think
or maybe
so.
that's the only kind of chemotherapy that causes damage to your teeth? I'm a little perplexed by the notion that it's by, you know, that option 2 has that follow on. I don't know. I'm confused. So
yeah.
Is there somebody from the Bureau that could help, or is there not? I'll get you in a sec, Representative Tepler. Colleen, is there someone from the Bureau who might
I know
help with
that
that piece?
Marty Hooper is maybe here, and Mr. Yardley. I'm not sure that they can comment on this specific language, but if they want to raise their hand, they can do that.
Okay, great. Representative Tepler, go ahead.
Thank you. And just seeking further clarity. If I have a diagnosis of breast cancer, but my doctor says he or she is unwilling to start chemotherapy treatment or surgery until I have my dental infections dealt with, which option? I mean, does option 1 applies there? Okay. So option 2 is only for head and neck cancer to provide treatment so that people can start chemotherapy. So if I have breast cancer and we choose option 2, I won't get coverage.
I think
that's right.
Yeah, I think that's a reasonable interpretation there.
I guess that confuses me, because it doesn't seem to me that we made that distinction when we were discussing this bill to begin with. So I'm curious why the Bureau chose to make that distinction.
I wonder if we actually might want to ask for one of the insurers to comment on this too, because it sounded like Colleen was suggesting that option 2 was the insurer's language.
Yeah, and I'm not sure that was what they were focused on either. I think part of why the Bureau why the analysis in the mandate report might have focused on that was for purposes of trying to provide different financial estimates under both versions of the language, and trying to find a distinction that would do that.
Okay.
But if there's someone who wants to comment, I mean, they can certainly comment. I think one of the other differences between the 2 versions was under option 1, there was language which wasn't really focused on so much in the Bureau's report, but under both versions, there was language related to routine dental care. And option 1 would have sought to allow fluoride services or fluoride treatment to be included. And under option 1, that was option 2, excuse me, that was more explicitly carved out, and language was included that would say a carrier is not required to provide coverage for routine preventive dental care, including cleaning, sealants, or fluoride services. So it wouldn't necessarily, I think the intent there is that it wouldn't be it would be focused on those medically necessary procedures tied to infection, decay, like we mentioned earlier.
Okay, Representative Evans.
Thank you, Madam Chair. I think part of the problem is that we're breaking it out into options 1 and options 2, specifically one for head and neck surgery or cancer, and the other for other cancers. But I'm not so certain that you can completely separate the two if someone especially is going to be undergoing chemotherapy or radiation. So I really think that we need to have that clarified and why they decided, other than the financial, the insurance aspect of it. I'm not satisfied that the two should be separate in the first place.
Okay. I do see someone in the attendee space who might be able to help us with this. Okay, Miss Awesomenfort, which is she's from Anthem, might be able to help us, so I'm going to bring her in.
Thank you, Senator Sanborn. Chris Awesomenfort with Anthem Blue Cross and Blue Shield. Let me start by saying I'm not sure how much I can help. I can just sort of maybe share with you our interpretation. I don't think we interpreted option 2 as necessarily limited to head and neck cancers. I think it's a very subtle distinction, but I think as we read option 1, it was sort of the would like to have versus the must have. Option 2 is what dental issues need to be addressed that are a barrier to treatment, either chemo or radiation, versus there may be an instance where, well, you've got an infection, that's not ideal, but we can still start your treatment. Option 1, I think, would cover those situations, whereas option 2 would be, we can't. And maybe that is head and neck cancers. I'm not sure, but I'm not sure that we interpreted it in such a limited fashion. And I'm sorry, I just realized that my camera was not on.
That's okay. So I was confused as to why the words medically necessary didn't do that work for you, because medically necessary is in option 1 as well. So I think that's where I was confused, is that, if it's not medically necessary prior to treatment, then it's not medically necessary prior to treatment. If it's not, I didn't understand why prior to versus to begin. As long as they're both medically necessary, it seems like they're medically necessary.
And that's certainly possible. Like I said, we were trying to there was different language, and we tried to apply the best interpretation that we could to figure out that distinction.
Okay. Yeah, I remember being confused about this last year too, so I'm not sure this is new confusion. It just was brought to a particular point of peak when we saw the report, I think. All right, I think that's helpful. Thank you. I'm going to put you back into the panel, into the attendee space. Thank you. All right, Representative Tepler.
Thank you, Madam Chair. I think that I am not comfortable voting on this piece of legislation until we have some more explanation from the Bureau of Insurance. So if we could ask them.
Yep. Marty just raised her hand, so I'm gonna bring her in.
Thank you.
Ms. Hooper is coming over. Good afternoon, Ms. Hooper. Can you unmute yourself and turn on your video? There you are. So can you help us with this at all?
I hope so. I looked quickly at the report to see if there could be some clarifying language, and I have the report in front of me. I probably can't share my screen, but I'll try to read out. So on page 3 at the bottom, we tried to explain our interpretation of the differences, that option 1 was treatment prior to the beginning of the cancer treatment, whereas option 2 was necessary to begin the cancer treatment. So it's kind of a fine distinction, but that's what we worked on for the estimate. And then to provide further clarification on the cost estimates, I'm going down to page 16 after Representative Tepler was concerned about the chemotherapy. So we broke it out into 4 groupings. It starts at the bottom of page 16, where it talks about radiation for cancer that's not head or neck. And then there's radiation for head or neck. Then there's chemotherapy, not head or neck, and then chemotherapy for head or neck. So I think there was contemplation that, yes, for chemotherapy, there would be treatment available under both of those options. So the distinguishing was the radiation, because it wasn't clear that radiation for a cancer that wasn't head or neck would affect the mouth. So I think it's difficult for non-medical people, but we did interview and do some research, and that was our understanding. So I know I went through that quickly and I have it in front of me. Did that help explain it? I see Representative Tepler still shaking her head.
Yeah, I do think we're going to probably need more time with the report, but I do see what you're saying on page 16 and going into 17, and it is kind of laid out into 4 groupings that make much more sense to me. I don't think I had looked at that part closely previously, but the information is there. So I'm going to need time to read that more closely. Representative Tepler, go ahead.
I continue to be confused because breaking out chemotherapy and radiation, I don't think makes a whole lot of sense. Often the two go hand in hand. One has chemotherapy followed by radiation. And we're talking also about a reduction in one's ability to fight off infection, some immunosuppression that comes from both of those things. So I'm very confused about the idea that radiation would only, treatment for infections in your teeth would only be indicated for radiation and head and neck therapy, head and neck cancer with radiation therapy. I mean, to me, that's very confusing, and it doesn't make sense in terms of the layering of therapies that often happens in cancer treatment.
Is that a question for Ms. Hooper?
Yes, I'd be happy to hear from Ms. Hooper how she interprets that scenario.
Yeah, I don't think I can give any more information. Like I said, I'm not enough of a medical person to go any further with that. That's just how the cost estimates were put together. So I think if there's needed clarification in the legal, in this language of the bill, I guess I would encourage that. But then the decisions would be made by the obviously by the dentist and the doctor involved.
And frankly, it may just be an argument for us to go with the broader language. The estimates aren't very different in terms, there are a few pennies different, and they have a range to them anyway. So, okay. I am going to suggest that we're headed for a motion to table on this one, just because we did not really understand the report or this morning when we were talking about it, and weren't able to really get to the substance of it because of this piece of it. So, but I don't want to cut off discussion by making such a motion prematurely. Is there any other discussion on the bill? Representative Brooks.
I just want to say, like, on the bill, I definitely support the bill. I think it's really critical that people have the dental body care they need, and particularly in the case of situations where it's really needed. That's needed all the time in my mind, but for cancer patients that need it before they can get the cancer treatment they need, that delay is challenging, to say the least. So I think that it's important to have coverage.
Okay. Seeing no further hands raised, I'm gonna move Ms. Hooper back to attendee. Thank you for your help. And I'm gonna go ahead and make a motion to table. Is there a second? Seconded by Representative Evans. Unless somebody wants a roll call on this, I think we'll do visual hands in the window. Okay. Stacy. Okay, it's unanimous of those present to table LD 665. Let's pick up 10:03 before we break for lunch. We will open a work session now on LD 10:03, an act to improve outcomes for persons with limb loss, and I'll ask Colleen to present.
So LD 1103, and this was a bill that was carried over again by the committee, and the committee discussed a proposed amendment that they forwarded to the Bureau of Insurance, and the Bureau of Insurance used that amendment for the purposes of their mandate review. So the amendment that the committee had developed as part of your discussion last session would replace the bill and instead require an insurer to provide coverage to enrollees under 18 years of age for one prosthetic device designed to meet an enrollee's recreational needs. The language of the amendment would be consistent with the current law, require coverage and payment that equals coverage provided for prosthetic devices provided under current federal law, which is what our existing mandate requires. Under current law, carriers are required to provide coverage for medically necessary prosthetic devices determined by the provider to adequately meet the medical needs of an enrollee. And there is a provision in the current law that says that prosthetic devices that are designed exclusively for athletic purposes are not required to be covered. So what LD 1103 would do as proposed would allow for an additional prosthetic device that would meet an enrollee's recreational needs for those under the age of 18. The report that the Bureau prepared on this bill notes between 144 and 322 children in Maine currently with limb loss. The committee should think about, if you move forward, an application date of 1/1/23 or later, thinking about the timing that for carriers in terms of proposing and implementing rates for the 2023 plan year. The Bureau's report notes some financial estimates ranging from 1 cent to 12 cents per member per month. The potential cost to defray benefits beyond the essential health benefits package, if the state were required to pay those, ranged between $9,000 and $89,000. And the report does note that Anthem did not believe they had sufficient claims experience to provide a specific estimate as to the impact on the state employee plan. I don't know if Ms. Austin-Fort has any updated information on that point. But I guess I'll stop there, and I'm happy to answer any questions. And if you wanted to see the actual language of the amendment, I could also pull that up for you as well, that you prepared last session for the purposes of the mandate report.
Okay. Are there questions for Colleen, Representative Tepler?
Colleen, I'm a little concerned about our language around the idea of recreation as I think about it. Does that include competitive sports? Because one of the concerns was that young people be able to participate with their specific type of prosthetic in competitive sports.
Well, what the language that the committee developed last year and forwarded to the Bureau of Insurance stated that the prosthetic device would be determined by the enrollee's provider to be the most appropriate model that adequately meets the recreational needs of the enrollee, as applicable, to maximize the enrollee's desire to ambulate, run, bike, and swim, and to maximize upper limb function. So it doesn't, it speaks to, you know, sort of those requirements to allow the person to ambulate, run, bike, and swim were what specifically were added to the committee. It does mention, it does speak to recreational needs. That's what the language says. It doesn't say competitive sports. As I mentioned, the current law does specifically exclude coverage for prosthetics that would be specific to, you know, for athletic purposes only. And that would continue to apply to someone who's over the age of 18. But for these purposes, it would allow for those under age 18 a second device, if you will, that could be used to meet their recreational needs.
Representative Connor.
Thank you, Madam Chair. Colleen, does it specify whether or not they can have multiples? I know my kids recreated with 5 or 6 different types of recreation, you know, before they were 18. If somebody recreates differently, does this bill in the current language allow them to get multiple types of prosthetics for different types of recreation?
The way this language is drafted, it talks about, in addition to a prosthetic device that meets their medical needs, a prosthetic device, you know, to meet their recreational needs. So as it's drafted now, I would not interpret it as allowing a carrier to cover more than one that meets their recreational needs. So it would be limited to one additional device under the statutory language. I mean, it could be possible that a carrier might cover more than one, but it wouldn't be required.
Okay. I see also the sponsor of the bill had wanted to add something here for us as well. So I am going to bring her in. Representative Madigan, welcome. Did you want to respond to Representative Connor's question?
I would agree with Ms. McCarthy that the way the amendment is written, it allows for one prosthetic device that meets the recreational needs. As far as I think people's concerns about whether it meets athletic needs, I think our concern in bringing this bill forward is just making sure that kids would be able to have the same developmental experiences that are so important to their peers. And that includes, you know, participating in gym class or, you know, youth soccer on Saturdays and things like that. So there are some things that are certainly athletic, but I don't think the intention of the bill was ever to have high-tech, super expensive, type things, that people in competitive Paralympics, kind of things. So what we want is just for kids to be able to have the same developmentally appropriate experiences that allow them to grow into fully functional, happy adults.
Representative Tepler, did you have your hand up? No, okay.
I
Okay.
was, sorry, I was going to ask for the insurance company's interpretation, but I think that Representative Madigan's comments make me more comfortable with the bill, and I'm happy to make a motion at some point when you're ready for that.
Thanks. I just wanted to discuss one more issue potentially with the Bureau or with Colleen, but sorry, our Colleen, Colleen McCarthy-Reed. So I mean, we can have a motion on the table while we're doing that, but I wanted to talk about the EHB defrayal in this context, and I think it'll be applicable to other bills as we're discussing going through as well. So Colleen McCarthy-Reed, I guess I'll start with you. There's in your chart, it's 9,000 to 89,000 as the impact of defraying the costs of this benefit under the ACA. Would that appear in a fiscal note?
It could. The Office of Fiscal and Program Review has not completed a final fiscal note. They will look at any amendment that the committee moves forward with. It could. I think it's more likely that it will be included as sort of a narrative description of potential costs rather than requiring a general fund appropriation for those costs. But I can certainly follow up with the Office of Fiscal and Program Review about that. Primarily because I think, as I mentioned earlier, I do not believe the state has been required, or any state has been required to date to pay the defrayal costs to the federal government for making any changes to a mandate that go beyond the essential health benefits package. That's not to say it couldn't happen in the future. So I guess the answer is maybe, and that would be something that they would discuss further. I think it's more likely that if the legislation moves forward and there is a potential cost to the state employee health plan, for instance, that's where you would see a requirement for a general fund appropriation to address those costs.
Okay, so can you speak to that part of your chart as well? It said no estimate was provided due to insufficient claims experience. The mandate report suggests that there's only 122 children with private regulatable health insurance in the whole state to whom this exists, or for whom this exists. So the likelihood that one of them is the child of a state employee is anybody's guess, but not a very high number. Is this going to be an indeterminate? I don't know how what's going to happen to this in the Senate. Is it going to go on the table if we were to pass it?
I think it would likely go on the table whether or not it has a specific appropriation or not, because I think if the bill moves forward, it would have a narrative description that would say something like, this may have the potential to increase general fund costs to the state employee plan, or something like that. And typically my experience is that they do refer those bills to the special appropriations table as well, even if there isn't a specific appropriation amount included as part of the fiscal note. So I wouldn't want to say that it would go through without being referred to the special appropriations table, because that's not my experience. So I would expect that it would, unless there was some further discussion, with those committee members. And, that has happened before, where there have been bills that have been sort of exempted from the table and then moved for enactment, rather than sort of referred to the table and then be considered along with all the other bills that have a potential general fund impact, prior to the end of the session.
Representative Bleier.
Thank you, Madam Chair. I do have a couple questions that I'm curious about. So after Representative Madigan spoke, I'm unclear if this is just intended for children to participate in sports, or if this is also going to provide prosthetics for competitive sports. So not sure the language really depicts that within the bill. And the second question I had for Colleen is this, is main care also going to be required to provide prosthetics to these children if the child is on main care?
To your second question about main care coverage, the legislation as it's put forward, LD 11-1003, only applies to Title 24A, sort of to health insurance coverage in the individual and group market. So if the committee wanted to make it applicable to main care, they'd have to amend another section of title of the statute. So, and we typically don't have jurisdiction over main care programs in this committee. So that would have to be done through a separate bill. And I don't actually recall whether or not the main care program currently provides this type of coverage. I could follow up on that if you'd like. On your first question about competitive sports, the way I read the language as was sort of shared with the Bureau of Insurance and talked about with the committee last session, it refers specifically to recreational needs of the enrollee. And there is a specific exclusion for coverage of prosthetics that are exclusively for athletic purposes. So if there is some desire among the committee to make it clear that it wouldn't apply in the competitive sport context, you could certainly add some language there. But I think the way it's drafted, I would interpret it to apply to, as I mentioned, sort of the recreational needs to run, bike, or swim, not a prosthetic that would meet the needs, those needs, as opposed to a prosthetic that would be required to meet their needs to participate in competitive sports. So it would be a determination by the enrollee's provider, but the language of the bill would sort of provide parameters under which they would determine which device would be most appropriate.
Colleen, going back to the EHB question, I did a little bit of research and it sounded like CMS was trying to get more specific about starting to have at least reports and reviews of states with regards to state mandated benefits over the last just 12 months or so. Do you know the status of that effort?
I'm aware of that. I don't have any specific update. I don't know if the Bureau may have had some further communications from CMS about sort of those reporting requirements or something that's going to be expected sort of in the next round of review of 2023, of the next plan year. They may have some further input on how far or how much that effort has progressed. I'm really familiar with it just as much as you, kind of in the context that you've mentioned it. That's something that is on their kind of radar, but to date it hasn't happened. The payments haven't been required yet.
And then when we worked on health hearing aids, I remember being very clear that it would not be defrayable because it was an expansion of a already mandated benefit. And I was wondering if there's a colorable claim here that this one is also an expansion or a clarification of an already mandated benefit.
I guess it could be, but I think they're really just two different things. I mean, I think the report that the Bureau noted, they did note that in their view, it would be seen as an additional benefit because it's a device for a separate purpose as opposed to the existing statute, which requires a prosthetic device that meets someone's medical needs. So they viewed it as a distinction. I think it's interesting argument could be made about it being potentially about it being an expansion of an existing mandate. I think when you get to talking about LD 1357, that's viewed as more of an expansion of an existing piece of what's already required under the essential health benefits package in terms of postpartum care. So I don't know if how much follow-up might be required, but that would be something that could be included. And I guess if it was something in the legislature's view that you viewed it as an expansion of an existing mandate, you may have an opportunity to either add it to the summary of the legislation or some unallocated language or something to sort of help that argument in the future if you were concerned about having to defray those costs.
That's what I was thinking, was that
Yeah.
if there was a purpose statement, or I know Maine doesn't tend to add those types of
No.
unallocated language, but sometimes there's a reason to do so.
Yep.
And given that what we're really doing here is saying, in the view of the Maine legislature, if we were to pass this, we would be saying that in the view of the Maine legislature, recreational development for kids is medically necessary, is part of the activities of daily living, and that the activities of daily living for a 60-year-old might only include walking, but the activities of daily living for a little kid include running,
Mhm.
and those types of things. So anyway, I was sort of playing with this in my mind to try and figure out how we could have as little chance of it getting hung up on the table as possible, because I really think the costs here are almost nil, and the benefit to the individuals who are implicated by this, which is a very small number of kids,
Mhm.
but the benefit to their lives could be really big. So anyway, I was just trying to come up with the ways that we might be able to tailor the legislation in that way. If there's anybody from the Bureau that has specific knowledge of the CMS efforts or what that might look like, could you raise your hand? Nobody wants to talk to us about this. Oh, Marty does. Okay, great. And bring Marty in. I think she's on her way. There she is. Okay. Good afternoon again, Ms. Hooper. Do you have any updates for us on where CMS is headed with this?
I'll try to give you a little bit more information. Colleen was right. It's something that's been evolving, and we have been keeping track of it, so that the most recent is what we refer to as a notice of benefit and payment parameter that is now in draft stages and accepting comments from the federal government. So there was a proposal that they stated their intent to remove the annual reporting requirement that was actually suggested to be due last July, was not enforced. We were anticipating having to report this July. And just to give you an idea of what we're talking about for the reporting, just kind of in brief summary, because I'm going off the top of my head, there would be a statement about mandates that were in place before the date of, I think it's 2011. And then there would be a comparison statement of the mandates that Maine has now. And then a determination that the state would make on whether there were any mandates that needed to be defrayed, the costs of those. And then CMS would review that and make their own determination. So certainly our concern would be that, we might have a determination that may not necessarily agree with CMS. And CMS does have, different criteria. And I think we've talked about, what that criteria is. I just wanted to kind of mention briefly, kind of following up on what Colleen said, there has been confusion about whether states are actually paying. And I tried to track down, I was under the impression there might be like 2 states that have got mandates that, would require. I think states like Maine have tried to find ways to, either define a mandate or like our hearing aid mandate, make it clear that it was, an expansion of a current mandate. So there have been some different process or language that, didn't require the defray. I did want to mention, kind of more specific to this one. We do have a mandate that passed, I don't remember what year, a few years ago, that required bone marrow testing. And there was concern, yep, that's a new mandate, that's a new benefit, but there really wasn't a cost associated with it. So I think what we would be looking for, like, let's say with this particular one, if it were to be determined a new mandate, is there a cost that the carriers are applying with regard to this, or is it really, more part of just the general coverage of prosthetics? So not trying to talk in circles, but that's, kind of the approach that we've taken with prior mandates. I'm just trying to think if there were any other points. Oh, yes, I did want to make a point that I also researched and found some discussion. I don't know if I can bring it up real quick. Some states approached new mandates by reevaluating their essential health benefit structure. And there is a process that you have to go through with the federal government to redefine your essential health benefit package and plan. And there have been a handful of states that have gone through that process to include new mandates. So hopefully that answered some of your questions.
Okay. Representative Morris.
Yes, thank you, Madam Chair. I actually had a few questions based on the report and based on some of the comments. One, so I think my reading on this report is we really don't have a full appreciation of what this might cost. It's around, right now, based on the limited experience, the estimate is around 12 cents, but it could potentially be more, it could be less. Is that an accurate way to say it?
Yes, that would be my interpretation of that. We try to estimate. I think these particular mandates are harder certainly than others. Like we mentioned, it's very small incidents, and we weren't completely sure what was required.
Right.
So there were some assumptions that were made about the type of coverage. And like I said, when we don't have the carriers giving us input, there isn't anything to kind of test that against.
What was the average estimate in terms of how much some of these prosthetics might cost? Was there any, what was the price that you got, price points you guys kind of assumed or looked at?
Yeah, I wish I had written the notes down ahead of time, because there are a couple different spots where there's some mentioned. I know there was a lower one mentioned of 3,000. That was for an upper body terminal device. And I think there's another amount, and going from memory, 50,000 perhaps for the actual prosthetic device. So I think there was different prices mentioned depending on what you were talking about. When we discussed and interviewed with the providers, they mentioned that you might have different components that attach to the device. So that's why there appears to be kind of a different range of costs mentioned.
Right. I just, because I've heard some of these, and maybe they wouldn't be this much for kids, but I've heard some of them can cost over 100. Obviously that's going to impact that more than the 12 cents, I would think. And you said, just to clarify, you're not aware of any other states that have this kind of mandate?
Correct. Yeah, the states have very similar language to ours that excludes for a specific athletic sport.
Okay, thank you.
Representative Morris, I would just, oh, excuse me, I was just.
I was
say-
going to point him to the right page.
Oh,
Go
good.
ahead,
Me too.
Colleen.
That's what I was going to say. So go ahead. If you've got it, I've got it. Page 16.
I was going
of
to
the
say
report.
on page 7 of the report, there's a discussion of the costs, and it appears they used $3,000, but said that the cost might be slightly higher under commercial insurance. So while components could cost up to $30,000 under the main care fee schedule, there's variation. And then there was the discussion with the prosthetist, and she indicated that there would be a lot of different choices, but would be able to meet most children's recreational needs for a cost of around $3,000 using the main care schedule. So I was just, that was sort of the discussion that was in the report. Representative Madigan, do you want to weigh in there as well?
I was just going to say the same thing. I mean, I thought the report mentioned that, because what we're really talking about is just, as you put it really well earlier, Senator Sanborn, that we're talking about the developmental needs of children. You know, just that recreation kind of is important for just their development. We want kids to be able to play with their peers, play hide and seek in their neighborhood, be able to not fall, you know, be able to have a prosthetic device that, you know, the ankle can move so they're not falling, you know, on cobblestones, or they can hike with their friends in the woods, build a tree house, that kind of stuff. So thank you. And it's really weird having another Colleen. This never happens to me.
Oh.
Like every time I hear your name, I'm like,
Representative Tepler, go ahead.
Thank you, Madam Chair. I have reached a point of being in strong support of this mandate. I mean, we are really talking about an extremely limited number of children. So the device costs being spread out among the members so that children can have a developmentally appropriate experience seems to me well worthwhile. We're not talking about a lot of money here in terms of increasing the cost of healthcare. And I think it's really important and something that we can do without creating huge healthcare costs. So I'm very much in favor of the bill, and we'll be happy to make a motion when appropriate.
Okay, Representative Morris, go ahead.
Thank you, Madam Chair. No, the reason I asked those questions and the reason I'm curious on all this is, again, it's just, there's not enough data. We have no problem. We certainly understand the support for the bill, and we're not opposed to it. We just would want to we wish there was more data available and more, because what we know is once something gets mandated, it can increase not just cost to the consumer, but it's the cost of the product itself now that insurance is mandated to cover it. So what I would support is, I would support this bill, but I'd like to see like a 5-year sunset with a report back to the committee so that there's an understanding of what the costs are going forward, is what I'd like to see, is just a sunset review on this with a report back to the Committee of Jurisdiction that just sort of says, this is who was covered, how many were covered, and what the cost was overall. And if it is if it is even if it's bigger than that 12 cents, I would still probably support it going forward for the reasons you mentioned. I just like to get an understanding of what that is before we make this a permanent law going forward.
Representative Tepler?
Thank you, Madam Chair. And respectfully, Representative Morris, I think that the limit is set by the number of children with limb loss. I don't think the cost per child is as much at issue. And unless you're expecting some kind of avalanche of increased numbers of children with limb loss, I think that is the parameter that really guides the decision here.
Well, I think we, as the insurance, as Marty Hooper said, we would be the first state to enact this type of mandate. And so we don't have the data, we don't have the experience to be able to know for certain how much it is going to cost. And I don't think it's unreasonable to ask for a 5-year, I mean, 5 years is a long period of time, sunset, so that we can get in with the Bureau being required to report back that cost, what this mandate has actually cost. I don't think that's an unreasonable thing. We're not saying I understand how a sunset review works, but we're not saying no to this mandate. We're just saying we need to have a better understanding going forward how much it costs.
Okay, Representative Brooks had her hand up next, Representative Tepler. So I need to keep moving around. Go ahead.
Sure. I was going to say that partially in relation to the discussion and also moving forward, I think it's really critical that I think back reading the testimony of the sponsor and why the bill was brought forward. I think it's really critical to let people know that in the tragic event that a limb is lost, we'll do what we can to support the needs of the person. This is more limited, but it's almost like, well, it's a small relative cost because it doesn't happen all that often, thankfully, but the difference it makes in their life is huge. And also we got to keep in mind that if somebody tries to recreate with a ill-fitting prosthetic, which people will do, I mean, if I need to run to get to a bus, I'm going to try to do that, whether I have a well-fitting prosthetic or not. So the preventative aspects of this, where it's preventing breakdown of the where they come together, the limb and the prosthetic, preventing that breakdown, infection, other complications. I mean, it's really just important in my mind, and I would definitely support this going forward. But that's my initial thoughts.
Thank you, Representative Brooks. Representative Tepler.
Thank you, Madam Chair. And I just want to say I'm not necessarily opposed to a 5-year sunset if the other caucus feels that's absolutely necessary. I'm just wondering if we've ever sunset a mandate before and how that is dealt with by insurers in terms of rate setting and that kind of stuff.
Okay. Representative Morris, do you want to answer that question?
Yes, actually, we just did it yesterday in the Labor Committee. It's been done dealing with some workers' comp rates. So it is possible. It has been done to sunset and do a review of it. It has been done, at least on that front, with some of those mandates.
Colleen, do you want to give us any additional context there from a HCIFS perspective?
Sure. Yes, I do recall that it has been done, with specific sunset of the legislation. It also has been, the legislature or the committee has also, with certain mandates, required annual reporting by the Bureau of Insurance about the claims experience with regard to those mandates, sort of outside of a sunset. Lyme disease claims, for instance, coverage of those, coverage of substance use disorder and the committee and coverage related to mammography services. So there are some annual reporting requirements that the Bureau has with regard to some mandates that are in place, and they report to the committee on an annual basis about their claims experience. So, if you did move forward with some sort of sunset plus a reporting requirement, I could look to that existing language and sort of model it. I use it as a model for this bill.
Representative Arford.
Yes, thank you. Just a few thoughts on this. I definitely support this bill. I think for anybody who's raised a child, it makes absolute sense that if that child has lost a limb and is unable to recreate with their peers, then that's going to have a profound and traumatic impact on them. What I'm wondering is, in lieu of a sunset, if we might just ask for the report back with the option of producing legislation based on whatever that report meant, if needed at that point in time. And the reason I suggest this is, I think the idea of passing this particular bill, which is actually providing a much needed service for these under 18-year-old Maine children who are unable to recreate freely without a device like this. That's what we're being told by the experts. And to pass a bill that says, well, then in X amount of years, we may be taking this away from you. I think that hinges on cruel. Not that I think we are choosing to do something that is cruel, but their perception of it might be, wait a second, I'm being given this service through my insurance. And then they're also saying that at some point in the near future, they may take it away from me. And I think there's a better way to go about, if what we want to truly assess is whether or not it's affordable after we've had a certain period of time to have it be in effect. I don't think we actually need to sunset it. I think we just need to have a report out on it.
Representative Evans.
Thank you, Madam Chair. I think that the intent of the bill by Representative Madigan will be met if we voted the bill out. Having said that, I do understand what Representative Morris is saying, but I think the choice of words may be somewhat of an obstacle. And I would agree with Representative Orford that if we use the language of a report back, that would fare better than sunset. The program would not necessarily end automatically. So I intend to support the bill, but I would have no objection to a report back to the committee. Thank you.
So Representative Madigan had her hand up next. So I'm going to go to her, and then we'll hear from the others with their hands up.
Thank you, Senator Sanborn. I appreciate Representative Morris is wanting more data, and I think that that's a great thing for us to have. And as the sponsor of the bill, I really like Representative Arford's suggestion, compromise to have the report back, because that would give us the data on how much this is needed, how many people it impacts, and how much it's costing. So that's just my 2 cents. Thank you.
Thanks, Representative Madigan. I'm going to throw out there that if we do put a reporting requirement in, I'm going to suggest that it not be annual, but be like after 4 years or something, because it's such a low incidence need, right? So few kids are going to be assisted annually, that we could have real data issues if we did it annually. So I'd propose maybe a 4-year report that then authorizes the committee to report out a bill in response to the report. So I'll just throw that out there for discussion, because I don't want to see this have annual reporting. I've read some of those annual reports and they're hard to understand, even for high incidence events, but I think they'd be really tough if we were only talking about 30 kids or something like that. Senator Brenner, go ahead.
Thank you, Madam Chair. I guess I'm never opposed to having more information, but I mean, the cost of this per member per month is so small that my question, I guess, is what is the cost to the state of a report back requirement with regard to the, balancing out how we spend our precious revenue? And I mean, are we really going to change our mind about whether or not we think it's the right thing to do to be able to offer this limbs to children? I mean, is it going to really change our opinion, or are we just asking for more and costing more and creating more bureaucracy? But at the end of the day, we all agree that the right thing to do is to pass this and offer children the limbs they deserve. So I guess I feel like the report back requirement, none of us might be sitting here in 4 years when that report comes back, and is there going to be someone that wants to read it, and will they make a different decision? I don't know. And is the expense worth it?
Thanks, Senator Brenner. Representative Morris.
Thank you, Madam Chair. I think that in this case, the expense is worth it because it's an expense to our healthcare system. And I frankly would like to see this on any mandate going forward, to have some sort of a report back to the committee about what its actual cost is to the people who have to pay the bill. So I don't think that, I think that we're interested in transparency too. And so I would be very interested in getting a report back on any time we pass a new mandate, just for that reason. As far as it goes, I think, we can certainly do with just the report back. Again, I'd still prefer to see the sunset, but if we can at least get some sort of a report. And it's really just because, also on page 15 of the report, it mentions $170,000 for a potential for a prosthetic arm or leg with a microprocessor. I don't know how many of those will actually be used. My guess is not many, but there's always that potential. There's always that potential. And again, I agree, we don't want to be in a position of taking something away. However, it would also, we're also talking about doing this only up to age 18. And so and I understand what your point was earlier, Senator, that the recreational needs of children, I have a niece and a nephew who's 5 years old, and he has much more stringent recreation needs than I do. There is no doubt about that.
All right. Thank you, Representative Morris. I feel like we may be in a place where we could potentially even get to a unanimous report. I'm going to thank our guests for joining us and move them back to the attendee space. If I get to the right people here, and then we'll continue our committee discussion. All right, Representative Tepler, go ahead.
I wanted to ask Representative Morris if he and his caucus would support a motion right now in favor of the bill with just the reporting requirement.
Well, I guess Representative Morris can answer that question if he wants to. But I also, I guess we could do a straw poll sort of situation if we wanted to. I don't want to put him on the spot to speak for his colleagues without the chance for him to talk to his colleagues, though, Representative Tepler. So I think, I think there are a couple of ways we could go about this. We could put a motion on the table. We could corner caucus and then put a motion on the table. But I don't think it's fair to ask Representative Morris to speak for his colleagues. Senator Stewart.
Thank you.
Thank you, Madam Chair. I would be fine with putting a motion on the table in the interest of time. And then I think we can see how it shakes out. And if we need to revisit it, after the fact, I think we can probably do that too, but I suspect I know how this is going to go.
Yeah, I do too. Okay, so does someone want to make a motion? Representative Tepler, go ahead.
Thank you, Madam Chair. I move ought to pass as amended with a report back after 4 years of the mandate being in place.
And with a January 1, 2023 effective date?
Yes.
Great. Senator Stewart, second? Great. Okay. So it's been moved and seconded. Is there further discussion? Colleen has a question, so let's hear from her.
I just didn't know if you wanted to include some of the language we talked about unallocated language to bolster any argument about defraying costs or not.
I would like to, if there's a creative way to do that. I think characterizing this as a clarification of what's required with regard to kids is
under the existing provisions. Yep. Okay. Oh, thank you.
All right. I don't see any other hands up at the moment, so it looks like we're ready for the question, and I'll have the clerk call the roll. You can go ahead and call the roll.
Okay, thank you.
Yeah.
Senator Sanborn.
Yes.
Senator Sanborn, yes. Senator Brenner.
Yes.
Senator Brenner, yes. Senator Stewart.
Yes.
Senator Stewart, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Representative Alford.
Yes.
Representative Alford, yes. Representative Bleier.
Yes.
Representative Bleier, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Malarano.
Yes.
Representative Malarano, yes. Representative Morris.
Yeah.
Representative Morris, yes. Representative Quinn.
Yes.
Representative Quinn, yes. 13 members of the committee voting in the affirmative, 0 in the negative.
Excellent. Okay. So we have 3 more bills to take up this afternoon. LD 1357 dealing with postpartum care, and then 2 bills dealing with infertility, 922 and 1539. I'm going to suggest that we have a lunch break now. How are people feeling? It's 1 o'clock already. Should we come back at 1:30, or does that give everyone enough time to get some food? 1:30. Does anyone need a longer time? Good. Okay.
Just so you know, I won't be
Senator
able to
Stewart.
join it this afternoon. I've got a class that meets at 1:20, but I'll be sure to register
Okay.
my votes with the presiding officers.
Thanks, Senator Stewart. It was nice to have the entire committee here. This might be the first time. So it was really nice to have the whole committee here this morning. And I think we got some good work done on the bills that we took up. So thank you for that. Representative Tepler, go ahead.
Yes. Can Representative Arford register her vote on the first bill we dealt with now, so that she doesn't have to go through the presiding officers?
Yes, LD 1776, is that the one you're talking about?
Yes, I am.
Yep. So the motion was ought to pass as amended on LD 1776, and if you could record Representative Arford's vote, that'd be great.
Yes. Representative Alford.
Yes.
Representative Alford, yes.
Okay, I think we're all caught up now. Is that right? Because we tabled the other 2 bills, right? Yeah. Okay, great. Good. Thanks, everybody. We'll see you back here at 1:30. And don't forget to turn off your video while we're on lunch break, or else you just have your video on YouTube.
Okay, we've got the majority of the committee back from lunch. And we are going to turn our attention next to LD 1357, an act to require private insurance coverage for maternity and postpartum care. And I will have Colleen present her overview.
Sure, thanks. I'm gonna share my screen. So this is LB 1357. The bill was amended by the sponsor to clarify that the intent was that it should apply to both individual and group plans, but as drafted, it would require coverage in individual and group plans that cover maternity benefits to provide coverage for postpartum care that meets the recommendations of the American College of Obstetricians and Gynecologists. And the bills, well, the bill references that coverage must encompass the recommendations of ACOG. It also does specify in the language that carriers should provide coverage for services related to postpartum care, including coverage for development of a postpartum care plan, contact with the patient within 3 weeks of the end of pregnancy, a comprehensive postpartum visit, including a full assessment of the patient's physical, social, and psychological well-being, treatment of complications of pregnancy and childbirth, including pelvic floor disorders and postpartum depression, assessment of risk factors for cardiovascular disease, and care related to pregnancy loss. The bill, as it was drafted and presented last session, would apply to policies and contracts issued and renewed on or after July 1 of 2022. Under current law, health insurers are required to provide coverage for postpartum care under the Essential Health Benefits Package. But I think what LD 1357 and acts to do is to sort of expand on those current requirements, and we'll note that further on in the discussion. In terms of the potential impact or scope of the legislation, if it moves forward, the report from the Bureau of Insurance notes an annual estimate of 3,000 live births in Maine that would be covered by insurance. They also noted generally that 5 of 6 carriers currently cover services provided in the proposal that would be medically necessary. But there are some differences in terms of that coverage, specifically related to the scope of how many postpartum care visits would be covered and the coverage of treatment of pelvic floor disorders. The proposal as drafted and under the guidelines would cover both a medically necessary and cosmetic treatment of pelvic floor disorders. And many of the carriers noted that their coverage that they provide now is for medically necessary treatment of those disorders. The language of the bill does not specifically address cost sharing. So if it moves forward, any cost sharing parameters would continue to apply based on the enrollee's health plan. The estimated impact on premiums in the Bureau's report is noted to be 54 cents per member per month. And they did break that down further in the report, and they attributed 13 cents per member per month for additional postpartum visits, and 41 cents per member per month would be related to additional treatment of pelvic floor disorders. As I mentioned, the Bureau's report views this as an expansion of a current benefit that's required under the Essential Health Benefits Package, not as a new benefit. So the report does not include any cost estimate related to defraying the costs, the state having to defray any costs of adding that to the Essential Health Benefits Package. The report does include, however, an estimate of the impact on costs of the state employee plan. The estimate that Anthem provided was $1.43 per member per month. It did note that there were differences between their estimate of premium impact and Anthem's estimate. And I don't know if you want to ask any further questions related to that. I would note, as we've talked about before, the application date. The committee should consider an application date of 1/1/23, I think at a minimum, but also consider what the timing and implementation needed for carriers related to filing rates for the 2023 plan year. And then lastly, an update. When you talked about this legislation last session, the sponsor, Senator Carney, also had introduced a bill to the Health and Human Services Committee related to postpartum care under the main care program, and that legislation was enacted. It would extend the postpartum period for coverage under main care from 60 days to 12 months, beginning July 1 of 2023 until the end of 2026 upon approval of a state plan amendment under the Medicaid program. And I guess I will stop there. I'm happy to answer any of your questions. And I did note that Senator Carney was here previously. I'm not sure if he's still in the attendee space, but I know folks from the Bureau of Insurance are still here as well.
Yes, and Senator Carney is also here, I'm pretty sure. Okay, questions for Colleen with regard to her analysis? Colleen, Representative Tepler has her physical hand up. Go ahead, Representative Tepler.
Thank you, Madam Chair. I'm sorry, I didn't think to reach for my raise hand function quickly enough. I think, Colleen, I'm not sure this question is for you, but I'll start with you. Do we understand where the figure in terms of the impacts on the state employee health plan comes from? And any sort of explanations of why that's so much higher than the per member per month in the general population?
We don't have any further explanation of that. I'm not sure if Ms. Ossenfort can speak to that. There are some existing requirements for infertility benefits now under the state employee plan, but they are limited, I think, to a $10,000 lifetime limit. And so it may be related to, maybe be partially related to that because it would expand the current requirements. I'm not sure.
Colleen, that's the wrong bill. We're talking about postpartum care, not.
Oh, I'm sorry. Yes, I'm sorry. Yes, sorry.
All right, easy to get confused.
Yes, I'm sorry about that. But the back to 1357, I don't think there's any further explanation or analysis of the estimate that's provided in the Bureau's report. So I don't have anything to add on the differences there.
Yeah, I have to say that I think that 3 times as much for state employee health plan as for the general impacts seems a little extreme. And I'd love to have a more explanation of that. And particularly, Ms. Ossenfort does have her hand up.
Yep, I'll bring her in. Go ahead, Ms. Ossenfort.
Thank you, and I'm sorry. I was actually coming back in from walking the dog, so I just want to clarify which bill you're on.
We are talking about the postpartum care bill, and the question was why is the state employee plan estimate almost 3 times as much as the collective impact estimate? And you may need to go back to your people to answer that, but that was the question that we had.
Yeah, so I can't speak to the estimate in the Bureau's report, but the estimate that we provided for the state employee health plan was in line with our estimates for the rest of our population. We estimated $1.46 for individual, $1.32 for small group, $1.52 for large group, and $1.43 for the state employee health plan. So it was in line with our estimates for the rest of our population. I can't speak to why the Bureau's consultant landed where they did, though.
I assume it's because a number of other carriers said that there would be no cost impact. So the blended rate comes down.
And possibly different assumptions as to what might be covered, what might be required versus what is covered today.
So I'm wondering if you can help me understand we heard a lot of testimony about people who were denied coverage for physical therapy. And I'm not clear if that was from Anthem specifically or from others, but your company does seem to have the highest assessed cost for what this mandate would impose as additional requirements. So I'm wondering if you can speak to why physical therapy for pelvic floor disorders is not deemed appropriate by Anthem, or if that is the largest component here of what we're changing in terms of the cost structure.
So I'm trying to look quickly at the information we provided back to the Bureau, because obviously it was a while ago, so I don't remember it all that well.
I think we have specifically like the responses from each insurance company, so I don't think we've seen that, although I could be wrong. Maybe it's at the very end here, but I don't see it.
I think you see our dollar estimates, but they ask us a lot of questions about coverage and other things that don't necessarily wind up in the report. I'm happy to look at it. I think that physical therapy is covered, but I need to look back at it to confirm that and try to be honest, I have not spent a lot of time on the report yet to try to identify areas that might be different in terms of assumptions or coverage or even the other carriers' responses.
Got it.
One of the things that might be helpful, I don't know if it is, but page 11 of the report sort of provides like a chart summary of some of the services and kind of outlines what's covered in the benchmark and then what carriers are covering. And if you look at the column related to pelvic floor disorder treatment, several of the carriers, it's indicated there that they provide coverage for medically necessary treatment. And I think that's where some of the distinction is in terms of the scope of the bill. As I understand it, it would provide broader coverage and sort of remove that medical necessity component to provide coverage for pelvic floor disorder treatment that might be considered cosmetic currently.
Representative Tepler.
Sure, I'm just wondering if while we have Ms. Ossenfort here, she could tell us what cosmetic pelvic floor treatment is.
And probably we'll need to give her time to go and ask someone that. I don't.
Yeah, I'm okay with that.
You're welcome.
Yeah, and I think that actually came from the consultant. So I'm not sure that we ever addressed that. So that may be a question better addressed to the Bureau.
Okay.
I'm just curious because your pelvic floor is not visible, generally speaking. And so I'm a little confused about what cosmetic pelvic floor treatment is. So if that's an issue, let's find that out.
Okay. Are there additional questions for Ms. Ossenfort? I want to take her off the hot seat here if we've asked the questions that we want her to go back to her team with. Okay, I'm going to move you back to the attendee space. Colleen, I think it would be helpful for the committee to see the actual language of the amendment in the bill. Could you pull that up and share it for us?
I'm going to try to share. Let's see, I think this might be the best way to share it right from the original bill, and the amendment would make this applicable to group in the group context as well. The original bill was just drafted to apply in the individual context, but this was the sort of the specific description of what would be covered that I mentioned earlier. Coverage for services related to postpartum care, including coverage for development of a postpartum care plan, contact with the patient within 3 weeks of the end of pregnancy, a comprehensive postpartum visit, including a full assessment of the patient's physical, social, and psychological well-being, treatment of complications of pregnancy and childbirth, specifically mentioning pelvic floor disorders and postpartum depression, and assessment of risk factors for cardiovascular disease and care related to pregnancy loss. And again, the language also specifies that the coverage must encompass the recommendations of the American College of Obstetricians and Gynecologists.
I'm sorry, my computer stopped working here for a second. I think I heard most of that. No, okay, I'm back now. My Bluetooth headphones decided to turn themselves on, even though in their case. Okay, so I guess the piece I wanted to try and tease out here is that there's nothing in here that specifically says cosmetic pelvic floor disorders have to be treated. I mean, I'm not sure I even know what that is, but it seems that a pelvic floor disorder, if it exists, it would be medically necessary to treat it. I guess I'm trying to figure out, it's not like we've taken away the concept of medical necessity in this amendment. I guess that's the question I'm trying to figure out. But that medical necessity includes the necessity to transition a patient to healthy and stable condition. Is that the nuance?
I think so. And I think we did hear, I think the report notes that there was a number of pieces of written testimony that the committee received from individuals who were covered by insurance and who were denied treatment for pelvic floor disorders. And I think a number of them noted that the reason why they were denied was on the basis of medical necessity. And so I think partly what the report might be noting is that folks in those categories, and maybe they're characterizing individuals in that situation as needing pelvic floor disorders for cosmetic purposes, but I think they're encompassing sort of those things that would not be considered medically necessary, and the language of the legislation would seem to point to an intent that all treatment for pelvic floor disorders would be required.
Okay.
And I guess if the committee wanted to put back in the medical necessity element to that, it may or may not solve the problems that some of the folks who testified about their particular situations, they may find themselves in the same situation, if you know what I mean.
Yeah, no, I do. Senator Brenner, go ahead.
Thanks, Colleen. So ACOG does not consider pelvic floor cosmetic surgery as medically necessary in their definition of things that are medically necessary. How could we amend this, and what would it want to say so that we could ensure that women were able to receive the types of support they need for pelvic floor structure support and therapy long-term for those 12 months? What would it need to say? Could it be amended so that we cover the service?
So I'm sorry, Stacy, can you say the beginning again? ACOG does not consider any pelvic floor treatment to be medically necessary?
No, it doesn't consider cosmetic pelvic floor surgery to be medically necessary. I don't believe we need to include cosmetic surgery in this piece of legislation, but I don't want the wording of the legislation to be construed so that it allows companies to get out of covering the procedure of supporting pelvic floor rebuilding and therapy and physical therapy and whatever a woman might need in order to support damage that happened and occurred during the course of carrying and giving birth.
Okay.
So we want women to, I want this legislation to come out of our committee with coverage for women for pelvic floor dysfunction that's medically necessary, not cosmetic. So I'm just wondering, how can we word it so that we can cover it?
Okay, got it. And that would be in line with the ACOG recommendations.
100%.
Okay, that's helpful. Representative Evans, go ahead.
Thank you, Madam Chair. I was just going to follow up on what Senator Brenner is saying. There's a very fine line as far as cosmetic versus normal pelvic floor repairs. And what we're speaking about here is during delivery, where oftentimes you will have to do some type of a pelvic floor repair. That in and of itself is not a cosmetic procedure. So I think eliminating the word cosmetic will allow for people to be treated appropriately.
The word cosmetics not in the bill, so that's not quite there. But yeah, that word isn't in the bill at the moment. But I think Senator Brenner's suggestion was that we just make clear that we follow ACOG guidelines with regard to the treatment of pelvic floor disorders.
Yes.
Yes, and that doesn't include cosmetic. That's true.
Right. Representative Tepler, go ahead.
I was just going to point out that there already is a reference to ACOG in the paragraph Colleen just shared with us. Is there some way we can emphasize that more, or use it to define the language that explains what we're trying to do? And I guess that's for Colleen.
Yes, I think so. I mean, I think it might benefit from sort of redrafting it, kind of to make it clear that coverage, to sort of put that first in the statement of what's required, that carriers must provide coverage for services related to postpartum care that meet the recommendations outlined in, the American College of Obstetricians and Gynecologists, and then sort of list out all the things that are required. And then maybe specifically with regard to pelvic floor disorders, make it, make the language more specific. That's what's meant, is that the treatment of pelvic floor disorders must be covered, in accordance with those guidelines. Maybe if you wanted to include the words medically necessary, you could, but to kind of redraft it to sort of put the focus on the guidelines, and then describe underneath that, if you thought that was necessary, some of the elements of what would be covered as part of the guidelines, not only the pelvic floor disorder treatment, but the postpartum care visits up to 12 months and, the other things that you've been talking about.
Yeah, I think that's the way to do it. And I think it's sort of already there, but it was certainly confusing enough, I think, to the Bureau or to the Novarest, that it might be worth clarifying or redrafting. Senator Carney has her hand up, and she's the sponsor of the bill, so I'm going to bring her in. Good afternoon, Senator Carney. Welcome to HCIFS.
Thank you. It's so nice to be here with all of you this afternoon. Thank you for all of the thoughtfulness in your discussion about this bill. I just wanted to raise one issue about the medical necessity versus cosmetic divide, because the women who testified before this committee last year did raise that they had been, for example, denied or limited coverage for physical therapy on the grounds that the physical therapy was not medically necessary. And yet the reason they needed it was because they were suffering from significant incontinence that was affecting their lives, all the time and in myriad different aspects of it. And so I would just urge the committee to, and it sounds like you do want to amend the bill to find language that would encompass providing physical therapy to patients who, because of an injury caused during childbirth, are, greatly impacted in their quality of life and in their day-to-day activities by incontinence and pain. I feel like we readily are able to get physical therapy if we strain an ankle or get a tennis elbow from playing sports, and yet we have, women who are bringing children into this world and aren't able to get physical therapy to repair an injury that makes them incontinent for the rest of their lives.
Yep. And I think, I don't know where everybody in the committee stands, but that's certainly my drafting goal. And I wasn't sure we had done it yet. But I think with Senator Brenner's help and Colleen's help, we can make sure the emphasis is there. I'm not sure I would use the word medical necessity. I think I want to emphasize the I like that word stable that's in there now. And just figure out how we healthy and stable condition, transition to a healthy, stable condition seems like a really good description of what is medically necessary. So I think Colleen can help us get there drafting wise. Representative Morris, go ahead.
Thank you, Madam Chair. I was going to defer to Representative Quint, but I would just say that I would agree with what has been said. I think I don't know that too many new mothers would be going through these therapies unless it was absolutely medically necessary. So,
yep, I agree. Representative Quint.
I was just going to echo that. I think one of the issues is if they're having to try to prove that it's a medical necessity. Obviously, women know whether or not they're having these issues. And I think bringing them to their doctor's attention and then having that questioned whether or not it's medically a necessity is something that we should be validating right out of the gate for this. This should not even be a discussion. After you go through a lot when you have a baby, and if you have outcomes afterwards that are producing, whether it's incontinence, and it can be just generalized pain. There are nerves there that can be affected. And if any sort of therapy can help with that, this definitely should just go into basic healthcare at this point.
Thank you, Representative Quint. Are there any additional, questions for the sponsor who's joining us still? All right, I don't see any. So Senator Carney, in our committee, it's more typical for us to move folks back to the attendee space. So we're going to do that.
Thank you.
Senator Carney and I sit together on judiciary, and we have slightly different customs with regard to Zoom. At this point, I think the outstanding issue in my mind really relates to Anthem and the state employee plan, but I'm not sure it's necessary for us to hold off on a vote in order to get further resolution on that issue down the road potentially, because that really impacts the fiscal note more than the language of the bill itself. So what is the pleasure of the committee? Senator Brenner.
Thank you, Madam Chair. I would like to move the bill as amended with language that will ensure that pelvic floor disorders are covered as part of routine postpartum treatment.
Okay. So Representative Evans, is that a second?
Yes.
Okay. Is there any further discussion on the motion? All right. Seeing none, I think we're ready for a roll call.
Colleen has her.
Oh, I'd just like to ask one clarifying question. Sorry. Application date of 1/1/23.
Yes.
Okay.
1/1/23, and I don't think we need to put any language in regarding expansion of current benefit. You don't think so either? Oh, you're on mute.
Yep, mute, sorry. I don't think so in this case because it is being viewed as an expansion of benefits unless you want to sort of reiterate that statement. You know, your agreement as a legislature that it is not an expansion. So, you know, I could include something and you can look at it, and if you think it's necessary, you can keep it. If you don't, you can take it
I
off.
kind of like the idea of including it on the easy calls if we're going to include it on the slightly closer calls as well.
Yep.
And, you know, I think it certainly helps make the case that we don't have to defray.
Sure, I'll include it. Thanks.
Okay. Are we ready for the roll call? Seeing no further hands, I'll have the clerk call the roll.
Thank you. Senator Sanborn.
Yes.
Senator Sanborn, yes. Senator Brenner.
Yes.
Senator Brenner, yes. Senator Stewart. Representative Tepler.
Yes.
Representative Tepler, yes. Representative Alford.
Yes.
Representative Alford, yes. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Representative Connor. Representative Evans.
Yes.
Representative Evans, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Malavango.
Yes.
Representative Malavango, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Quinn.
Yes.
Representative Quinn, yes.
Edna, did you register Representative Connor's vote?
No.
Okay, Representative Connor, do you want to vote again?
Yes.
Okay, Representative Connor, yes. 12 members of the committee having voted in the affirmative, 0 in the negative.
Great, thank you. Okay, and thank you to Senator Carney for bringing us that bill. Next up, we are going to turn our focus to LD 922 and 1539, and I think they're combined in the same report. So Colleen will give us her analysis together on them. Did you analyze them separately, Colleen? I don't have your chart in front of me.
No, I did them together.
Perfect.
And actually, I did want to clarify, the committee actually only has one bill that was carried over, LD 1539.
Oh.
LD 922 was voted on not to pass.
Oh, okay.
And you asked the Bureau to look at, you know, the impact or the cost impact related to both bills if you decided to just move forward with a smaller version, which would be 922 versus the more comprehensive LD 1539. So just want to clarify that.
We have one vehicle to use either way.
Right.
Okay, perfect.
So you just only, you do only have one bill, although if you needed more, you have some options to think about too, I suppose.
Okay.
But LD 1539, as I mentioned, is the more comprehensive proposal. The committee made some small sort of technical changes to the original bill related to how some of the definitions, but nothing really substantive. The original proposal, which the Bureau looked at, would require carriers offering health plans in Maine to provide coverage for sort of three components: for diagnostic care, for fertility, for fertility treatment, if the enrollee is a fertility patient, and then also for fertility preservation services. And as it was drafted, it would apply to health plans issued or renewed on or after January 1 of 2023. For the purposes of the report, the committee also asked the Bureau to look at the impact of a proposal that would be focused only on fertility preservation services, which is what LD 922 proposed. And that proposal would require carriers to provide coverage for fertility preservation services when necessary cancer treatment may indirectly or directly cause infertility. As I mentioned, LD 1539 is a broader requirement for coverage. The Bureau's report notes an estimated 47,000 people in Maine may experience fertility difficulties, and approximately 700 may need fertility preservation services. If you're thinking about the scope of or the impact of the proposed legislation, cost sharing parameters would continue to apply. There's no specific separate cost sharing laid out in the legislation. LD 1539 specifies that carriers may impose cost sharing for these services as long as there are no differences in treatment between cost sharing for other services. So it would require, as it's drafted, any cost sharing that's applied for other services would have to be applied to fertility treatment in the same manner. But you may want to think about, as you move forward, different cost sharing parameters potentially. And if you did, that may impact costs. We talked about the application date. As LD 1539 is drafted, it would include a suggested date of 1/1/23. The financial impacts that are estimated in the Bureau's mandate report range from an impact on premiums for LD 1539 of $5.03 to $6.32 per member per month. The impact of LD 922 would be smaller, 11 cents to 21 cents per member per month. They did include an element of potential costs to the state to defray costs of benefits beyond the essential health benefits package. For the broader legislation, LD 1539, that's estimated to be between 3.7 million and to 4.8 million. And for LD 922, 79,000 to 159,000. And Anthem's estimate on potential costs to the state employee health plan is $8.28 per member per month. I'm happy to stop there. I can pull up any of the specific information that you need from the report. I just also wanted to note that the committee did receive some additional written testimony on this bill that's come in the last day or so, and some this morning from folks interested in this legislation. And I think some of them may also be here in the attendee space, as well as folks from the Bureau of Insurance.
Thanks, Colleen. Questions from the committee for Colleen? All right, my questions relate to what other states have done with regard to cost sharing, and I don't know who the best expert on that might be. It was raised in one of the letters, I think, that one of the folks sent to us. Senator
Davina Funkhauser might be the right choice.
Okay.
If maybe they might be able to raise their hand. If this would be a question they can answer.
Okay, great. Thank you for the reminder as to which advocate it was. Thank you.
Hello.
Good afternoon. Thanks for joining us. Can you introduce us yourself and remind us what organization you're with?
My name's Davina Fankhauser. I'm with the organization Fertility Within Reach.
And my question was about what other states that have mandated fertility coverage have done with regard to cost sharing.
And honestly, it varies state to state. Some have a deductible that they require. Rhode Island does this. Massachusetts just basically says whatever you do for maternity, you then do for fertility health care. So there's no consistent requirement or recommendation that's put into place. It's whatever seems to be best for the state and its residents.
So we had a suggestion, Ms. Funkhauser, from one of our insurers that we put in place a benefit design that's similar to what the state employee plan has today, which is a $10,000 lifetime maximum. Can you speak to whether that type of benefit design is in place in any of the states that have mandated coverage?
No, no. I do believe that the state of Utah has $4,000 coverage, and it's a trial that they're trying for a couple of years to have in their Medicaid plan. 4,000 can go towards fertility benefits or adoption. But no other state has such a small amount, because it wouldn't even cover one treatment that would be required for, let's say, if they needed IVF. It would not. It would basically cover diagnostics and medication type therapies.
Okay. Do you know if there are any states that have a lifetime cap at all?
I believe Rhode Island has a $100,000 cap.
Okay. How many states currently have a mandate with regard to fertility treatment?
Well, regarding fertility treatment, that's greater. That's about 17 states. Not all of those states require IVF. So state 12, and so just to clarify what that means is they may require diagnostic care, initial fertility treatment up to the point of IVF, which is really the burden that rests on patients. So this is, I would say 12 states have coverage, I believe, with IVF coverage, and most of those states have expanded their coverage to include fertility preservation.
Okay. And then there's a larger universe that require the other pieces, but not IVF.
I don't believe that they're larger. I think the larger is the states that do cover IVF. That I would say that's 80% of the states that have a mandate require the IVF. I think there's maybe 2 or 3 that don't.
Okay.
Sorry if my math is off there.
No, that's okay. That's helpful context. Representative Morris.
Yes, thank you, Madam Chair. I don't know. I don't think it was your group, but we did get more testimony this morning that referenced the New Hampshire apparently has a law along these lines. As I am reading it, New Hampshire does not, their mandate only applies to group health plans, not to individual plans, correct?
That is correct. And I did help co-author that legislation and lobby for it. Okay. So I'm familiar if you have any other questions.
And so that does not apply to IVF either. That's only fertility treatments.
No, that includes, I'm sorry to interrupt.
Oh, no, yeah, that's all I was asking. So interrupt right away.
Yeah, it includes IVF, third-party reproduction. Yes, everything.
So another question along those lines, and I haven't seen the law itself. I'm only reading the FAQ.
Okay.
They have to be diagnosed with infertility first, though. Was it something along those lines? It was.
I'm trying to remember the law in front of me because we had to amend that, but I don't believe we said that they had to have a diagnosis. Kate Weldon LeBlanc, who is also an observer right now, she would also be able to address that. But I don't believe, because not every individual has a diagnosis of infertility. So for example, if somebody has, they're born without a uterus, they require fertility treatment, but they haven't tried to conceive for a year in order to meet that definition of infertility. So that's why it was, it's to make it possible for those with a medical need.
Right. And again, only reading the FAQ, it seems to indicate that it might require a diagnosis of infertility.
Okay.
And again, it's only reading the FAQ on it.
Okay.
That's all. Yeah.
Okay. Ms. Funkhauser, can you speak to why it was tailored to just apply to group contracts as opposed to individual market plans as well?
That was something that was important to their state. So this was something I think they considered it new. They chose not to do a cost analysis for the bill that we had. And so I think they were just starting slowly with the idea that they could expand later.
Okay. Sorry, I had a sneeze.
Yeah. Oh, bless you.
Great. Thank you. Representative Evans, go ahead.
Thank you, Madam Chair. Mrs. Frankhauser, you mentioned earlier that there were 12 states that were allowing the IVF workup. Once you get to that point, did they have caps on the actual treatment beyond that point?
Rhode Island had a cap.
Out of the 12?
Yes.
Okay, thank you.
So you're welcome. My expertise is on cost analyses, so I'm happy to address any questions you have.
Are there additional questions for Ms. Funkhauser? Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you for being here, Ms. Funkhauser. In your opinion, having observed a variety of states' approach to this, which one do you think works the best to serve people equitably across an income distribution?
Right. That's a great question. I do think that we looked at the main legislation trying to encompass the best practices. So looking at what other states did, looked at what worked and what didn't work for patients or the professionals, really looking for a win-win. And that's what we tried to create for Maine. So I think having a dollar limit, I never like, because I feel that creates a disparity, because some forms of infertility require more expensive treatment or care than others. So they may have fewer treatments than other people, if that makes sense. Does that answer your question?
Not entirely. I guess I'm concerned that one of the issues we have with infertility treatment is that it has become the domain of people with financial ability. And my concern is that whatever we do, we don't continue that trend, that we enable people who don't have financial ability to receive a benefit that is similar to those who do have financial ability. And that's sort of where I'm coming from. And I'm not sure that what you answered is a response to that.
Well, I'll try to answer better. I feel infertility is a disease that impacts the reproductive system, and regardless of what your income is, having healthcare to support it is important, because this, even if you are fairly, middle class and up, having this type of financial hit can really shock any budget that a person or a household may have. So I understand, to really help those who are, perhaps middle class or below, that's where I was, and that's where my heart, focuses. But I do think that this is a healthcare disease that should be available for all people, coverage for all people.
Representative Evans.
Thank you, Madam Chair. Sorry to keep bothering you, Ms. Frank
Oh,
House.
no.
In your experience, what you may not be able to answer this, but do you have any idea regarding success rates?
Well, yes, and they're public. What can I help you with?
As far as people who do go through the whole process, how many of those patients are subsequently able to go forward and deliver?
Okay. Well, I'm going to be very honest with you, and I'll try to be as clear as possible, because there are national averages, but there's also, it can vary depending on the clinic, the type of practice that they run. I was just reading a study that last night that said those who transfer a single embryo transfer, it could be around 30% success rate. And of course, those who maybe don't have benefits and want to transfer more to increase their chances because of financial burdens, they would have a greater percentage of success rate. It also depends if they're using donor egg. If somebody requires a younger egg, that percentage rate is going to be, 40% or higher. So it's such a complex health issue that the answer really does vary. But the success rates and the science is improving literally every year. And hopefully this, the way that this bill has been written, it will provide coverage even as the science evolves in the future. But the success rates are increasing consistently.
Okay, thank you very much.
Yeah, which is great, because then you don't need or require as many cycles.
Thank you so much for that answer.
You're welcome.
Representative Quinn.
Yes, thank you. This is not my usual scope of practice here. So is there a certain, with these other bills in the other states, are there like parameters put on that? Are there age limits? Is there a certain amount of time in which they're infertile before this starts to apply to them if they don't have a diagnosis of infertility?
Right. So what we've seen is that varies by state. Some states, like Massachusetts, there is no age, there is no limit. But the Division of Insurance allows the insurance carriers to create some guidelines that have to be based by current evidence, not just arbitrary. And other states do put an age limit. For example, Connecticut had put an age limit of 40, but then they determined that it was a violation of the Affordable Care Act because the treatment is effective past the age of 40. So therefore, the insurance commissioner increased the age without changing the law. So it depends on the bill.
Representative Quint, go ahead and have a follow-up.
Yes, sorry. Just the second part of the question, is there, because I know we're talking about diagnosis of infertility. So do they have put into those bills, like what that is? Are there time limits? If somebody is just saying like 1 year into it, or is there, like I said, this isn't my normal realm.
That's okay. No, that's fine. And I appreciate the follow-up question. So some states do have it in their legislation that you would be required to attempt to conceive a certain amount of time. One of the risk factors of that was originally in Massachusetts in 1987, but the recommendations changed that if you were over 35, it was good to seek treatment or evaluation after 6 months of trying. So there is some danger in putting concrete timelines. Also, there's a state, Hawaii, requires you to try to conceive for multiple years before you're eligible for benefits. And this can be a hardship on patients who may be of older age, 38, 39. So there are some states that do, but many states do not.
Representative Brooks.
Yes, thank you for your expertise in this area. I really appreciate it. A lot of thoughts come to mind. I mean, I think of a friend of mine who took on a second job, which became her primary job, for the insurance benefits for fertility treatment. And over time, not to reveal who that friend may be, but over time, she actually was able to conceive her own children. And so it does work. And I think it's really an important benefit. My question for you is, looking at the different state models, I like the way our statute is drawn up here. But I think also just really basic things like folate, you know, if we had some sort of fertility treatment or education along with the diagnostics, like how do we get intervention to help people learn about menstrual cycles and learn about things that can promote, that would be very inexpensive.
Right. And that typically is, I'll kind of show you this. This is part of our policymakers guide to fertility health benefits. This is usually the order of recommendations through a doctor's office. So just so you understand, it's very rare that a patient would go straight to IVF. That might be somebody who does not have fallopian tubes, or so I'm not a doctor, so I can't give you all the medical examples, but just to give you an idea that 97% of fertility issues are handled without assisted reproductive technology. Only 3% require this advanced medical care. So by having coverage for diagnostics and the basic fertility treatment, you are enabling, being able to help many be able to build a family. But it's really, for me, a question of, again, it's a disease. And sometimes you need to go extra treatment to overcome a disease, like heart health. Did that answer your question?
Yes, and that person I mentioned, I mean, the couple had gotten fertility treatments and required therapeutics to get to that point. And waiting is just such a deleterious thing when we're talking medical and other consequences of delaying and stuff. So I just appreciate bringing the bill forward and your expertise on the matter.
Thank you.
Representative Tepler.
Thank you, Madam Chair. And thank you, Ms. Fankhauser. I'm not sure if my question is for you or for Colleen. I'm curious to find out, not today, but sometime in the future, if the experience of other states, since there are quite a few other states that seem to have some form of fertility protection, is in line with the estimates that we've been given of the cost to a per member per month level.
Right. And I can address that. Just because I've worked with so many states on their cost analyses, not every state handles the cost analysis the way that the state of Maine did. Really, ideally, the way to figure out the actual costs, the most accurate, is to look at the claims data, how many patients that they have covered, what types of diagnostic codes they have covered. That really helps you identify the actual cost to Maine. Other states are not including maternity care and birth, which the insurers, I have been communicated with, they look at a health benefit and then 18 months forward, which includes then maternity care. But they already do protections for maternity care in the state. And unless they're subtracting the infertile population from that, these individuals are already covered. So that this is why a lot of states do not include adding maternity care into the estimate, which is usually one of the most expensive parts of that cost. And we saw that in the report that was done. I think it was the second most expensive cost, was the maternity or additional birth.
Just a follow-up, if I might. So since we are looking at 1357, which covers maternity care here, the estimate that we were given for the cost for 1539 includes also postpartum care and maternity care?
It includes additional births. Yes.
Okay, so we're double counting to some extent.
Yes. Yes.
Okay, thank you.
Exactly. You're welcome. Colleen, would you agree that that was, I'm sorry.
I don't think, I mean, I think that's what the report said. Colleen, did you want to weigh in on that?
No, I don't want to necessarily. I mean, the report lays out where their analysis is looking at the potential. I focused on additional births and sort of multiple pregnancies as a result. The Bureau can speak to it further, but if you look at, I think that discussion is on pages 20 to 22 of the report, specifically about how they address that issue.
Okay. Senator Brenner.
Thank you, Madam Chair. So in my experience as a nurse midwife with families that are experiencing infertility, usually it's like a year to a year and a half in of working with them before they feel ready to take the referral to the infertility clinic. But it's such an intimate process that when you're engaged with a couple who's working so hard to get pregnant. So, you know, in that office visit with an obstetrician or a nurse midwife, even sometimes with a family practitioner, depending on where you're located, I mean, you're working through like ovulatory cycles and taking temperatures and how to time everything. And you can't even start the workup in that private office. You know, you're looking for things like, you know, background diseases that could perhaps be treated so that you can affect the fertility. So much happens in the office atmosphere before a patient even gets to the fertility clinic. I mean, nobody wants to add extra visits and an extra long process to what should be this, you know, kind of fun thing, right? You're gonna make a baby, like that should be fun. And so when you hit that point where you've been 6 months, a year, 18 months in, I mean, you're in a pretty devastated place by the time you get that referral to the fertility clinic. So I think adding the restriction of timing of how long you've tried, it could potentially be quite insulting, I think, to couples, depending on where they are in their life cycle.
Yeah, I do find that it doesn't apply to everybody. So it can actually do more harm than help. And I think, you know, I read the report and how it talked about what they think the potential is that could utilize this benefit. But the reality is, one, not everybody seeks treatment. And especially for fertility preservation and in youth, we really have to educate and encourage them. And a lot of parents do not want to discuss this option with their children when they're younger. So even though the potential is there, the reality is, and other research from states show, there's something called a pent-up utilization that really only 10 to 30% of people or 10 to 30% will be an increase in the number of cycles that already exist. And then it will eventually level off and then drop down. So you're right. Having this timeline it is not necessarily helpful in any way. I don't really see a benefit to it because I think, like I said, there are patients where trying for a year is actually against the recommended healthcare. And if you don't mind me saying, yeah, I had an undiagnosed blood clotting disorder, and I've had 10 pregnancies. And I was finally able to have my 2 children through IVF, and I had to be on a blood thinner from the moment I conceived in order to not lose the pregnancies. But it took me 12 years to figure that out because I did not have insurance coverage for diagnostics or basic care. So what could be saved in the long run, even though they had difficulty calculating it, I can assure you between mental health benefits and care post miscarriage, it's a lot. That was a lot more than reimbursing for an IVF cycle.
Thank you. Are there additional questions for Ms. Funkhauser? Okay, I'm going to move you back into the attendee space and thank you for all the information you provided.
Thank you.
Okay. Is there additional committee discussion on the bill? Giving people a minute. Representative Tepler, go ahead.
Thank you, Madam Chair. I feel like I need some more time to think about this and look at some of the different models in different states and fully absorb all the information that we have. So, I mean, in my mind, I would definitely prefer not to vote on this today, but to take a little more time with it.
Yep, I was wondering if it might be helpful. I don't want to make a bunch of work for Colleen that we aren't going to look at, but I feel like it would be really helpful to have like a one pager, and maybe there's one that exists on the internet somewhere or that the advocates have already put together that kind of lays out what the different states are that have it and what the parameters are in those different states. And I don't really want it for a work session. I kind of want it before the next work, like to look at in caucus before the next work session, to just kind of have a sense of where people or where other states are in their benefit design. And because I think that might be helpful to us in sort of having an array of options, at least in front of us. And a bunch of different kind of ways of approaching this from a benefit design standpoint. Colleen, do you think that's a resource that could be pulled together pretty? I don't want to make you do a ton of work.
I think so. I mean, I think as was stated earlier, I mean, there are really a lot of differences among the states in terms of how they treat it, in terms of how they define what infertility is, in terms of the time frame and stuff. But and there are some visuals where you could sort of see a map of states, and the states that have addressed it in some way might be highlighted. So I could definitely provide you with something like that. But what I
think Health Organization has a state-by-state analysis.
They do,
okay.
Yeah.
And maybe it's just a link to that is all we need, Colleen, and then we can run down the rabbit hole ourselves. I just didn't want to just Google it randomly and see if I could find it.
No, I think that'd be helpful. I mean, I was thinking maybe it might be helpful to sort of lay out some of the elements of like, is in a chart quickly, like is cost sharing limited, and all the states are listed, and you might say, okay, this state it's 20%, no more than 20%, or this state it's, you have to be 5 years, or in this state it's you have to have an age between 18 and 44. I was trying to think of some quick way to kind of identify for you some of the benefit design elements that you mentioned. And so maybe I can pull together something like that in addition to some of the existing resources that are out there. And I can certainly include in that, links to the specific statute so you can see, because there are some states that don't include individual plans. There are states that exempt smaller group plans. There are states that, have lots of different limits of the, 19 that have enacted legislation like this. There's a lot of variation and some similarities. And maybe, if you can just see check marks, you can kind of pick out where the similarities are and where the differences are, or something like that.
Okay, thank you. Representative Morris, go ahead.
Yes, thank you, Madam Chair. And Colleen, if we could get to some, as I talked about with the New Hampshire law, where they don't include the individual plans, obviously we've got the other complication of next year moving to a merged market and how it's going to impact that. So maybe it's a question of looking at what it would do if we did just large group something, and even all the other parameters and so forth. My dog's barking too. She's crazy.
Your dogs made my dog bark. They thought that there was someone in the room, so they
No, it worked.
out of here. I'm sorry about that, everybody. And now I have to call on people. Representative Quint, go ahead.
Thank you, Senator Sanborn. You actually asked my exact question. I was going to ask for the same thing because like I said, I don't have a lot of information on this, but I was wondering if there's a second part to it. And I'm not sure if, I think it's Ms. Funkhauser, her organization may have that, of when they were first putting the bills in place, what their guesstimates were for what it would cost. And then to find out if that actually ended up being the case, if they did in fact align with that, if they were less than, more than, that would be helpful. I'm just not sure if someone has a way to get that information as well. Thank you.
I suspect she has it at least for one state because she referenced it in her letter, and I do think cost projections is her specialty. So we might be right in her wheelhouse, and she could send, I'm speaking to her now in the attendee space, and I know she's listening, but she could send the committee an email or a letter helping us with some of that data to the extent it exists. Representative Tepler.
Thank you, Madam Chair. And I want to point out that the New Hampshire bill rolls the equivalent of 922, which is the other bill on fertility treatment that's before the committee that was analyzed, into its general fertility treatment law and addresses particularly fertility preservation for cancer patients.
I think our bill as written addresses fertility preservation for anyone. Is that right, Colleen?
Yes, yes. LD 1539 is comprehensive and it includes fertility preservation services, diagnostic and treatment. So it's all of the subsets, I guess, including 922. And I think it, as Senator Sanborn said, it goes a little further than it's a little broader than 922 as drafted, as it would apply to anyone, not limited to just a cancer diagnosis particularly.
Right. Okay, so we've asked for some additional information. I don't see anyone else's hand up looking for additional information. Is there any further committee discussion before we table the bill? All right, seeing none, I'll entertain a motion to table if someone wants to make one. Senator Brenner.
I make a motion to table.
Okay, seconded by Representative Connor. And it looks to me like it'll be an uncontested vote. So please put your hand in the window if you agree. Representative Evans. Excellent. Okay, so it's unanimous motion to table on that bill. So I think we have reached the end of our work session today. I don't think we have anybody with us right now that didn't get to vote on all of the bills we voted on today. Is that right?
That's right. I think we've got everybody from earlier this morning. It was just Representative Arford.
Okay. Great. So in that case, unless anyone has any announcements, I think we are adjourned.
I do have two things that I could bring back to you for a quick language review, given that we're not going to meet again this week, if you wouldn't mind.
Yeah, no, that's fine. If you've got stuff ready, I think we could do language review right now unless anyone objects.
Okay, great. I just have the two bills that you voted last week, one which was 1783, which you reconsidered, which just to show that change to you quickly, and 1855, which is the bill dealing with point of dispensing sites.
Okay.
Given that that one has an emergency, I wanted to try to move it quickly if possible. So I'll share them real quick.
Great.
I'll go to 1783 first, which I think you can see. You might recall when you voted the bill on, we've reconsidered the vote on this bill. You wanted to add to the notice provision here in paragraph B that the notice must be to the covered person prior to or within 7 days of the acceptance of financial assistance. This bill relates to the copay accumulator programs or financial assistance programs that companies have for prescription drugs. So that's the revised and updated amendment to LD 1783. That one was quick. And then the second one, this is LD 1855. You voted to add an emergency preamble to the bill. And I just wanted to show that to you quickly, just stating that the previous legislation that was enacted last session authorized COVID-19 vaccine administration at point of dispensing sites during the public health emergency declared by the governor. And since that is expired, there's still a need for point of dispensing sites, and this would provide that access, but still require the delegation of administration beyond a declared emergency, but still subject to a memorandum of understanding with the Department of Health and Human Services and requirements for training and oversight. So that would add that emergency preamble and emergency clause to LD 1855.
Great. I don't see any hands up, so I think we're all set with those being reported out. And I don't know if Edna's done the confirmation on those yet, but if not, please everybody look for those emails from Edna in your email and get those turned around with an approved response as soon as you can, so that we can report out bills and get them passed through the House and the Senate. Representative Tepler.
Thank you, Madam Chair. I got a question this morning about the next set of confirmation hearings that we might have to have and what the soonest dates we could set for those are. What was the thinking on that? I'm wondering, so we can sort of have that in mind.
Representative Tepler, I think that's a scheduling question that you and Colleen and I would discuss offline.
Okay.
Because there aren't any currently pending confirmations in front of us. Nobody's been appointed yet or recommended for confirmation yet.
I'm sorry, I apologize. I thought that they were.
Nope.
Okay.
The one last thing I wanted to mention is we do have a divided report that the committee voted, the only one I think we have so far. That's ready to be reported out. It's LD 1778. That was the bill related to expanding the duties of the Office of Affordable Health Care. And because it's a divided report, you'll be getting an email from Edna. All of the members of the committee asking for approval of your signature, electronic signature on the jacket. So folks should just be aware of that and try to get back to Edna. It's also, I guess, if you're here on Thursday, you could drop in and sort of give her that verbal authorization as well. But I know she's going to be sending that email out to you. And I just wanted folks to flag that. Most of the others, since they're unanimous, they go to the chairs for approval. But when it's a divided report, every member has to provide the authorization. So thanks.
I just assumed everybody got it. In my other committee, they're all divided reports, so I was confused. Okay, Got it. Well, folks will be looking for that on any divided report, that email from Edna, and just write back approved if your vote is correctly recorded, and then we'll be able to turn around these the processing piece. Usually we do it in pen when you're in the committee room. So this will be very helpful if we can keep things moving along. I think we're going to have session at least once a week starting on Thursday. So we'll get back in the cadence of moving some paper through. All right, unless there's anything else. I certainly could talk about scheduling now if that was helpful to Colleen, Representative Tepler.
Send a link. Thanks.
All right, thanks everybody. We'll see you on Thursday.
Bye.
Bye.